In the next half an hour, we'll be talking a little bit about diagnosis and monitoring and run through with a great panel. I thought I'll just give a brief introduction before we get into the discussion. And this is a fairly focused audience, but I assume there'll be some students in this audience. CML is a fairly common malignancy in adults, and that's the worldwide incidence, about 1 to 2 cases per 100,000, can occur at any age. Median age is 57 years. And we recognize that in Asia and probably Africa, we get patients at a much younger age. Children and adolescents can account for less than 5%, and generally most recommendations that are available refer to adults. Very basics, and this has already been covered, I touched on, but I just want to kind of focus again for the purpose of some students that may be in the audience. Basically, the driver mutation is reserved for translocation between 922, resulting, as you can see in this karyotype, all you can see is a small chromosome 22, and that's what was described as a minute chromosome. But on the idiogram, we know what is happening is actually a reciprocal translocation between chromosome 9 and 22. And we are particularly interested in what happens on chromosome 22, where the Abelson gene moves from 9 onto 22. The Abelson gene has a lot of regulatory elements which it loses in this process and comes adjacent to BCR. And now the Abelson becomes constitutively expressed and is not regulated by its normal regulatory elements. Before we go into diagnosis, I think it's important for students to just kind of understand the major structure of the breakpoints that one sees. In the Abelson gene, the break happens in particularly one location, but on BCR, it can happen on the following points. Intron 1 between intron 13 and 14, and rarely in intron 19. So the breakpoints that one sees is usually you see a movement of this Abelson onto the BCR. So you can imagine if it happens over here, you have a very small component of the BCR and the entire Abelson gene. And that's what's referred to as E1, that is exon 1, only of the BCR, and A2, which is a consistent break. While the B3A2 and B2A2, the previous terminologies, essentially refers to breaks over here, where this portion of the BCR starting from exon 3 is represented, and A2 goes and joins over there. And similarly, you have E13 and E14A2. If the breakpoint is here, you have exon 19 of BCR, up to exon 19 of BCR, and A2 of BCR coming and fusing over here. As a result, you can easily visualize that P190, when it's the minor BCR, is the smallest transcript, while P210 and P230 are the larger transcripts. There could, of course, be additional isoforms which may not be recognized, and they are very minor variants. But it's important to keep this in mind. The treatment goals, it's important to recognize in CML has changed. It's disease which is associated with practically normal survival, and we're in fact talking about treatment-free remissions as a standard accepted goal. So for that becomes very important, as Dr. Advani alluded right in the beginning. All patients should have, as much as possible, obviously access to care, but more important, appropriate diagnosis, early intervention, and appropriate monitoring. I think this is important. While there'll be a lot of variations of what the panel discussed with regards to their individual practices, as much as possible, we will try, for the purpose of this discussion, to stick to what is standard accepted recommendations. And I urge students in this audience to look at these two documents. One is the European Leukemia Net 2020, which has come out, and the NCCN 2019. For the most part, they are kind of similar, and a few variations that are there in this area we will talk about. So with regards to my topic, I've added the component of prognostication because I think diagnosis, prognostication, and monitoring kind of go hand in hand. The panel has already been announced to us. We have with us Dr. Prashant Ganeshan, Dr. Nikhil Parker, Dr. Deepak Mishra, Dr. Vashish Manya, Dr. Bharti Malhotra, and Dr. Nitin Sood. All of them are well known to you all, and they are all authorities in their own right. So we'll start very quickly with the case. We have a 45-year-old man who presents with just increased fatigue of 5 months duration. He's got a splenomegaly, and those are his blood counts, a hemoglobin, a WBC, which is elevated. I'm not going into the details. It's a left shift, but it typically looks like CML, and a platelet is 300,000 per millimeter cube. We do strongly suspect CML in this particular patient. So my first question is to Dr. Prashant Ganeshan. What baseline investigation will you do to diagnose CML? Prashant, are you there?
Yeah, I was muted. Yeah, thank you,
Okay.
Dr.
Okay.
Yeah, Dr. Vikram. So the baseline investigation, first to confirm the diagnosis of CML, we generally have to do a BCR ABL. I generally prefer to do a qualitative BCR ABL PCR. That's what we usually do. Plus, we would do a bone marrow aspiration and a biopsy. This would be the baseline investigation to confirm the diagnosis. Maybe we'll just get an X-ray and ECG as a routine for most patients. So that would be about it for a young patient with CML. That would be about it. Get the things going.
Okay, so this is what ELN recommends. Would you want to just talk a little bit about the importance of biochemical profile and hepatitis B serology, though this is away from the actual diagnosis, but as part of a baseline workup, and why you think they talk about it?
Yeah, generally because any chemotherapy or any kind of anti-cancer therapy, when we start, we generally want to look at the hepatitis B serology because of the prevalence is not unusual in our population. So we want to know that in case somebody is positive, we want to put them on some antiviral medications. That's one thing. Gives an idea about the liver status also. And the other thing is you want to talk about the ECG. Is that what you said, sir?
No, the biochemistry profile. I'm just trying to get why is that there as part of the...
Right. So the biochemistry profile, again, to get a general idea about the kidney function test and the liver function test, because we're going to use medications like imatinib, dasatinib, and nilotinib. These are the usual first-line agents. And some of these, like the nilotinib and dasatinib, are known to have a proportion of patients can have hepatotoxicity, particularly nilotinib. We do encounter significant hepatotoxicity. So we want to know the baseline status. And the ECG, of course, also goes hand in hand with some of these drugs, like nilotinib is known to cause QTC problems.
Thanks, Dr. Prashant. I think the important thing is the biochemical profile is all important because especially when you're choosing drugs, you may choose one over the other depending on what kind of comorbidities exist and some amount of data on hepatitis reactivation of some of these infections that one has to worry about with these agents. Moving on, we do a bone marrow aspirate as suggested. We do a bone marrow aspirate because I think most people do this because the proportion of blasts and basophils are important to distinguish between CT from accelerated phase and blast crisis. So to Dr. Deepak Mishra, would you do a trophine and a core biopsy? And if you would do this, why would you do this? Deepak Mishra, are you there?
Yes, I'm there. Am I audible?
Yeah.
Yes.
Yes, you're audible.
Though primarily chronic myeloid leukemia is the diagnosis from peripheral blood, but yet, as per guidelines, though not many people do it, trophine or core biopsy is important because many times we can miss out on the information on bone marrow fibrosis, as well as sometimes the blasts are clustered in the biopsy. So though it is BC in peripheral blood, sometimes can be AP on bone marrow trophine. So it is important to do the trophine biopsy.
Thank you so much. I think that's exactly what Yellen says. I agree. And the practices do vary. We certainly don't do a trophine for everybody. But the recommendation is to consider doing a biopsy because you could identify a degree of fibrosis and possibly nests of blast. A nest of blast does not necessarily make it a blast crisis by definition, but they may have some prognostic implications. The next question is to Dr. Vashisht Malhotra. What are high-risk additional cytogenic abnormalities and what is its relevance? Vashisht, are you there?
Sir, he got logged out right now, sir.
Okay, so can I request anybody to take it? I can happy to help you out with because nobody's expected to remember these offhand. Can I ask Nikhil to take this? Hey, Nikhil.
Hi, sir.
Hey.
I really don't remember this offhand.
Yeah,
but
not a problem, Nikhil. It's there in ELN 2020. You can see it on your screen.
So I think
they've defined those as high-risk additional cytogenic abnormalities.
So trisomy 8, second PH chromosome and isochromy 17q, monosomy 7, an 11q23 rearrangement. Basically, any evidence that there is genomic instability will mean that the patient is likely to be, having a more aggressive behavior. So which is why it's good to do.
Fair enough. Yeah. I think, while we do look for it, I think that's exactly what Nikhil said. I think the only shift has been that in the current recommendations compared to ELN 2013, where it was just a warning, The current recommendations say if you have these, you're supposed to move the patient, even if by conventional so-called and ELTS scores, if they come as low risk, you move them into high risk, and you approach them as high risk in terms of decision on treatment and monitoring, etc. So for that small reason, nobody is expected to remember every one of these high-risk ACAs, but you just need to, if you see additional ones, you want to know if this is a high-risk additional surgical abnormality or not, and you may want to deal with that appropriately.
The other advantage of bone marrow is, could I just say one line?
I'm sorry?
Could I just comment? The other advantage of doing the marrow is that you'll be doing conventional karyotyping and can see all of the additional cytogenetic abnormalities.
Correct.
Along with
absolutely.
So if I might just come in, we don't get this very often. So do you have any feel of how often do we see something like this, sir?
I don't have the data, Prashant. I really don't have the data. And I honestly have not looked it up. So, but it has to be a reasonable number of patients for it to actually come into the guidelines. So it's worth looking that up. If anybody finds the data while this is going on, it will be useful to add to the discussion. So the next question is to Nikhil. Nikhil, ELN recommends a qualitative RT-PCR, while NCCN recommends a quantitative RT-PCR at diagnosis. What is your practice and what is the philosophy behind one versus the other at diagnosis? We'll take that question first, and then we'll go to the role of NGS at diagnosis.
So, in our hospital, what we practice is we do both a quantitative PCR as well as a quantitative PCR at diagnosis. The rationale for doing a qualitative PCR, if you ask me what one test it is that you should do a qualitative PCR. Simple reason that if almost 98% of the times you will be right if you do a simple qPCR, and you will catch the E13A2 and E14A2 transcripts. But beyond that, there are alternatively spliced transcripts where the ABL exons change. You have rare fusions that take place which are not E13 or E14. You can have E1A2, you can have E19A2, E6A2, and many others, which should be known that if you get these particular fusions, a normal quantitative PCR is going to be false negative, because almost all of them exclusively look at E13A2 and E14A2. So that is the rationale for doing this. Now, why would you like to do a quantitative PCR at diagnosis is because it helps you establish a baseline. Although you do that, you must remember that at very high levels, there is a skew associated with BCR-ABL. And the levels are actually false because you end up quantitating ABL twice because there is so much of BCR-ABL. So,
okay, thanks. So I think the basic thing is, the premise is that at diagnosis, we need essentially to identify the isoform because that's how you will track it later. And there's a danger that you don't want to miss it as much as possible. But I guess both are good enough as long as you can ensure that you can identify the isoform that's involved. What about the role of NGS at diagnosis, Nikhil? And again, I'm sticking to standard recommendations.
So I don't think there is any role for doing kinase domain testing in standard risk AML.
Not kinase domain, I'm talking about just NGS.
Of panel-based NGS testing at diagnosis. There is emerging data to show now that if patients have a presentation in an accelerated phase or blast crisis, they may have somatic mutations such as in RUNX1 and other genes which may predict that these patients will do badly. But it is by no standard of care. It's under
Thank you. Thanks, Nikhil. To Dr. Bharati Malhotra, how would you define accelerated phase and blast crisis at diagnosis? Is Bharati there?
Yeah, I'm there. Can you hear me? Yeah.
Yes, we can hear you.
Yeah, there are different organizations have their different classifications, like European.
I'll put it up here. It's mainly for education. You can walk us through that. Okay.
Yeah. So the European Leukemia Network says the blasts or the bone marrow in the blood and the bone marrow should be 15 to 29%. And the basophils in the blood should be like more than 20%. The persistent thrombocytopenia less than 100 10^9 per liter. And the clonal chromosomal abnormalities in the Philadelphia positive cells should be there. While the WHO criteria says the blasts should be 10 to 19%. And another difference is that the thrombocytosis more than 1000 into 10^9 unresponsive to therapy is also considered as accelerated phase. and increasing spleen size and increasing WBC count unresponsive to therapy. So a lot of things are overlapping, and that depends on the clinical case. One has to decide. Similarly, in blast phase, ELN says that the blast should be more than 30%, and while the WHO criteria says the blast should be in the blood or the bone marrow should be more than 20%, and they also say that the large foci or the clusters of blasts in bone marrow biopsy, if they are present, then it is again considered as blast phase. But in practical situations, things are a little overlapping, and then you have to decide on individual case basis.
Right. Thank you so much. So I think many of us use WHO, but I mean, that's really left up to you. The criteria are out there, and usually it's not a subtle diagnosis. It's usually there for you to see. What are the prognostic systems available, and what is currently recommended by ELN? Dr. Nitin Sood, could you take that, please?
Sir, good evening.
Good evening.
I hope you're doing well.
Yeah,
so,
we're good.
I mean, there are various prognostic systems that are recommended. I mean, the age-old SoCal used to be there that we all used in the past. But then the Euro score came in, and the UTOS and ELTS, which is just a derivative of UTOS. So ELN now recommends UTOS. And most of the scoring systems are based on the spleen size, thrombocytopenia, sort of percentage of blasts in the peripheral blood, age, and
actually, Dr. Nitin, the ELN currently recommends modification. It's called the UTOS long-term survival. It's called an ELTS score.
Yeah, so that's just
Not
a derivative of UTOS. That's what I was saying.
Yes, fair enough.
So, I mean, I think the premise behind doing the scoring systems is because they say that, I mean, high risk patients may not respond as well as the low and intermediate risk patients do. So the choice of treatment, although overall survival in various trials is not different, so sometimes the choice of treatment may depend on, and it may push you towards the more potent second generation TKIs.
Okay, thanks. So I think basically what people found was the conventional scores, there was really no significant changes in survival with the conventional TKI-based therapy. It was probably more relevant in the pre-TKI era. In the TKI era, we are more interested in what is the leukemia-related transformation and leukemia-related deaths, and which is what ELTS picks up. So just like what Dr. Nitin said, basically the parameters are the same, but the weightage given to age is significantly less in the ELTS score. So what happens is essentially you get many more patients in ELTS. If you do the same population and you apply both SOCAL and ELTS, you will get many more patients moving to low risk compared to the SOCAL score. But you see that the ELTS picks up 6-year leukemia-related deaths better than the SOCAL score. And essentially that's what the ELTS score is supposed to do. That's why ELN recommends it. With regard to monitoring and how often to monitor, Vashisht is not here. Would any one of the panelists want to take this?
I think
I can help you with the slide set which walks you through what the ELN says, but you can give it your
the ELN states that the first time point of monitoring is at 3 months, where you expect it should be less than 10% if it is ideally responding. And at 6 months, and then at 12 months, and then subsequently once in a year. So that is standard guideline that ELN stipulates, besides the normal blood count and other things.
So I think one difference is in the quantitative PCR, ELN essentially says 3 months for life almost, while NCCN kind of says that once you reach less than a major molecular response, you can drop it to once in 6 months. I think that's a subtle difference. And of course, you can use FISH if you don't have a well recognized or a very rare transcript that you can't recognize by PCR. The basics of molecular monitoring, I'm not going to walk through this, but I just want to emphasize to clinicians like us, Dr. Deepak Mishra, the importance of knowing the copy number of the control gene when we read out these values. Could you just stress that for the audience, please?
Yes, so because it is very important that the housekeeping gene amplification is optimal. As Dr. Chatai has said before, that minimum 10,000 ABL1 copies should be amplified to make a valid report. So if you want to go along the MR3, MR4, 4.5 and 5, it is all based on the number of housekeeping genes that you could amplify. So if you want to get a deeper response, deeper molecular response, so the higher the housekeeping gene copy number, we could amplify. That will say that if it is more than 100,000, so it is MR5, and below that is undetectable.
Right. Thank you so much. So I think again for the clinicians, remember if you see a value of MR5 and you don't have the housekeeping ABL gene copy number in that report, be cautious about interpreting it. And if you do have the housekeeping gene copy number reported, it should be more than 100,000 to make that interpretation. And similarly for the other cutoffs. And these are the definitions of complete cytogenetic response, major molecular response, MR4, MR4.5, and MR5. Again, I'm sure most of you all are familiar with this. Basically refers to the log reduction from diagnosis. What are the molecular milestones, Dr. Nitin Sood? Can you walk us rapidly through that, please?
I mean, again, so the question really is to look at the kinetics of the BCR-ABL and how it's dropping, which is why we like to do a baseline qPCR. And at 3 months, we at least like 1 log reduction. 6 months, we like 2 log reductions, which is kind of equivalent to the old cytogenetic response. And at 12 months, it should be less than 0.1%, which is 3 log reduction. And at any time, ELN says it should be less than 0.1. And if it's not, then it's a warning sign and you should look into.
Okay, thanks so much. There's a slight variation with NCCN. For the most part, it's overlapping. At ELN at 12 months, if you're more than 1 person, you're considered a failure. But in NCCN, as you can see from this, only at more than 15 months, if you're more than 1 person, is considered a failure. At 12 months, it's still considered a warning, as illustrated by this yellow sign over there. What is the role and future of DNA PCR and droplet digital PCR in CML diagnosis and molecular monitoring? This is to Dr. Deepak Mishra,
Yes.
who I know has some experience in doing this and
yes,
has...
So we have been doing the digital droplet PCR for quite some time now. And I think many of the laboratories will move because ddPCR is a wonderful tool for rare event detection. So now Biorad has a US FDA validated kit available, and it gives the result in higher scale. So it can be directly integrated into the treatment algorithms. The other thing is that the DNA PCR is, I think, going to be the future of monitoring. And if you look at the Title II study, it shows that in the first 3 months, it is not very relevant because it is always higher than the qPCR. But as you move on, there is a fair amount of concordance. And I think it can monitor even after the qPCR is undetectable. So DNA PCR technically is easier to do because it doesn't have the issue of RNA degradation and other things, sample transportation. So as more and more data comes in, I think DNA PCR is going to be the future tool for disease monitoring in surveillance.
Thanks. Okay. So you really feel there's a role going forward for both of these technologies?
Yes.
Okay. Thanks. It's, I think I just want to stress that it's currently not part of standard recommendation, but I think that's the consensus that many people, what Dr. Deepak Mishra echoes, the thought of many people in this field. This is to Dr. Prashant. When would you consider doing a BCR-ABL kinase domain mutation? Not just in this patient, but in any patient.
We will do a kinase mutation in case there is a failure of therapy, or even sometimes when we are not, when we are seeing these warning signs also, sometimes we may want to do, but generally when there is a definite failure of therapy and we are considering switching to a 2nd generation TKI for any other reason or another TKIs, that's when we should definitely do a BCR-ABL kinase domain mutation. Sometimes in a newly diagnosed patient with accelerated phase or blast crisis, sometimes we just do, but I don't know whether that's part of a general recommendation at this point of time.
No,
so definitely
this is the standard recommendation, but I think what you're saying is an important point, that whenever you're considering changing, you should think about doing, whatever the indication, you might want to consider doing this once, right? And of course, there are these mutations and the associated drugs. Nobody is expected to remember this. You're always expected to go back and look at a table. If you find a mutation, to decide what is the drug of choice. T315I, we all know, is ponatinib as the drug of choice. Now, to Dr. Nikhil. Nikhil, what is the preferred method for BCR-ABL kinase domain mutation testing? And when it is indicated? I mean, I'm not talking about doing it all the time. Say, as Dr. Prashant said, there are indications for it. when those indications arrive, what is the preferred method of testing and why?
So the preferred method
Nikhil, are you
of
there?
testing. Yes, sir. Sir.
Yeah. What?
Yeah. The
Would
preferred
you use Sanger or
method.
NGS essentially?
So far we've been doing only Sanger, but there are new recommendations on board which say that next generation sequencing is to be used. The reason why they do that is that there is an obvious level of cutoff which is there at of 20% of mutation burden with Sanger, and with next generation sequencing you can go as low as 3%. So you can detect those low-level mutations which have been shown to have an influence on outcome, as well as these subclones also can influence therapy. So which is why it is important to do that.
Perfect. Thank you so much. So just like Dr. Nikhil said, and this is taken straight from the ELN guidelines. The BCR-ABL mutations by Sanger, the sensitivity is 20%, can go up to 33% by NGS. And the greatest sensitivity of NGS is not an academic exercise. It could be clinically relevant and could potentially impact your therapy. And there are cross-references for that. For those who are interested, can look up the publication in 2019 in Blood and Lancet Hematology. So Prashant, everybody's talking about deep molecular response. What is deep molecular response and what is its relevance to treatment-free remission?
So deep molecular response is anything with a BCR-ABL IS level of less than 0.01%. And earlier studies used to stop when it was below 0.0032%. But the current recommendation of stopping, safely stopping a TKI for a treatment-free remission strategy is to go below 0.01%. So any patient who wants to try a TFR strategy should get to below this level. So that is the relevance of the deep molecular response.
So greater than 4 log reduction is generally considered deep molecular response. And the relevance of that, and these are the values of patients who have treated on the studies that are available now, the CML4 study, Ernest and Dacion. It's interesting to see comparing where data is available in all. If you can look at imatinib at 4.5, 53% at 5 years versus nilotinib, 54%, and dasatinib, 42%. It's very similar, and it's very interesting to know that long-term follow-up, patients continue to drop their values. And their relevance to TFR is, this is the recommendation from ELN. And as Prashant said, you want patients to achieve a certain level of what is called deep molecular response, not only achieve it, but sustain and maintain that for a certain period of time, which is defined before you would consider these patients for a treatment-free remission. With that, I'll take one quick round from each of the panelists for any additional thoughts that they want to convey to the audience. We'll start with Dr. Prashant.
Nothing specific from my side.
Yeah, not a problem. If you don't have anything, you can just pass. Dr. Nikhil?
I have no questions. No.
Any practical challenges or issues that you face in the real world?
So main concern that you must understand is that BCR-ABL is best developed in your own city. It is we are not America, where it is easy to ship samples in a cold chain. All that stuff is very difficult. So most important is to have local expertise and develop this test. Invest in it. Invest in your laboratory personnel.
I think it's a very important point, Nikhil. You're talking about pre-analytical variables. And when we ship samples, I mean, those are issues for every clinician to consider seriously. Anything else, Nikhil?
I just want to add, we had done a study with Dr. Reddish. We had transported samples stored on a filter paper, and they did a BCR-ABL quantification, and they did matched very well. And so that could be one way if you do not have a facility of quantification in your own city. So these could be stored on the filter paper and then transported to the lab, because that saves a lot of dry ice and cold chain transportation issues.
Absolutely, Dr. Bharti. I think that those are the interesting new technologies that have real potential and very practical and very relevant, and your group has done good work in this area.
And another thing is, I would like to add, yeah, I'm in a government setup and basically a microbiologist, and you must be wondering how I'm there. So, like in a government setup, most of the labs now, microbiology labs have gene expert machines are available through the TB control program. So, this test can be very easily be done. These machines can be used for doing the BCR-able quantification. You only need to pay for the cartridge. The machine is already there in the system. And once some negotiation is done with the firms, so that could, really help in doing the BCR-able monitoring right in your own city.
Fair enough. Dr. Bharti, I think that's a very relevant point. The only reason I didn't go there is because it doesn't come in, currently it doesn't come in standard recommendations, but I think we have our own challenges and we have to work and address our own challenges. And I think that's an important point that you're bringing up. We need more work in that area. Dr. Deepak?
Yes, I'll have 2 points. I will agree with Dr. Bharti that if you go through the Max Foundation, the cost of the cartridges come down. So you can reduce the cost. Second is, I will agree with Nikhil that sooner we should shift to the NGS mode of PKD mutation detection, because nearly the whole of Europe has shifted from Sanger to NGS. And 20% and 3%, the difference of gap is quite a bit. And I think many patients who are suboptimally responding probably are missing out on the PKD mutation.
Thank you. And finally, Dr. Nitin?
I can see time is up, so I'll pass.
Okay.
Time is up, so Vikram, can
Thank you, everybody.
quickly?
Thank you, sir.
We've summarized, we have finished, we've gone through it. Thank you so much. I want to thank all the panelists for their time, and I thank the organizers again. I hand it back to the organizers.
Thank you, Vikram. Beautifully moderated.
Thank you for the great moderation and invitation.
Thank you.
Thank you, everyone, for the wonderful session. We'll move on to our next session. This is a session sponsored by Novartis, and the speaker is Dr. Biochemistry Profile, medical oncologist from Mumbai. Over to you, sir.
Yeah, sure. So I'll start sharing my screen in a moment. And at the outset, I would like to thank Advani sir for guiding us, interesting us in the field of medical oncology, not only the medical oncology, but all the oncology field in the country. And this is an excellent way to contribute to this cause in our capacity. Is my slide visible?
Yes, sir, it's visible, sir.
Yeah. So the task given to me is to speak on the role of second generation TKI in the CML. This was more or less of a theoretical discussion earlier days when we didn't had easy access to second generation TKI. But right now we have, most of the people would have second generation TKI accessible even at diagnosis, and this question becomes more and more relevant now in our setup as well. I will try to go through different options available to us at this time point. Then we'll look at the importance of depth and timing of responses, which we saw in the last panel discussion. We'll see data on the upfront second generation TKI in terms of efficacy, safety, and long-term outcomes. And this is mainly with the Nilotinib. We'll also see its implication for deeper responses, and mainly that's for TFRs in newly diagnosed patient, and also in a patient who is on Imatinib but is not eligible for TFR. So would second generation TKI help us for that? And next is, when second generation TKI fails, what do we do? That's the important question which has not been really answered adequately as of now. The goal of treatment of CML is changing as we have more effective measures. So not only the prolonging survival and control of the disease is our goal, but now our goal is to have deeper levels of responses. So the complete cytogenetic responses, EMR, MMR, and even deeper responses leading to ultimately what we call as practical cure. So patient is off TKI, but he is still having low level of disease, and that's our goal. And towards this goal, we have different options available as of now. And these are the different TKI available to us. So Imatinib, Nilotinib, Dasatinib, and Bosutinib all have been approved for first-line treatment in CML chronic phase patient. This is a bit old table. So Bosutinib has been approved as well, and these are the different doses for first-line and second-line treatment. As you can see, the IC50 of these drugs to inhibit BCR-ABL is different. So if you go from Imatinib to Nilotinib to Dasatinib, the IC50 of this goes on decreasing. So that speaks in terms of potency of the drugs, and Above that, you can see that what we can achieve with the recommended dosing. So the well above IC50, we could achieve the trough level of most of these drugs. This slide also shows the different inhibition of different kinases like PDGFR, KIT, SRC, and this would be helpful for us to predict the side effects, as well as if you want to use TKI for some other indication. Probably it's important to have a look at this kinase activity. Moving on, the importance of time and depth of responses. So we saw how the drugs are active, they are leading to deeper responses. So we first talk about EMR. So we saw beautifully that at 3-month testing is done. If it is less than 10%, we call is early molecular responses. And this has been shown to predict the superior overall survival, event-free survival, MMR, deep molecular rate, and for MR 4.5. Its value in the presence of achievement of other milestones is not very clear. So like someone has achieved CCIR, what is his additional value? Or someone has achieved MMR, we don't know what's his additional value. There are some issues also. This is a one-time value, so this is not really reliable. We don't need to know what is the starting point of that individual patient, and for that a halving time can be very useful. And a subsequent PCR would also be useful for this patient. And first thing is there is limited data to act on this as of now in clinical practice. So this is from German CML4 study, and what it tries to show is your chances of achieving a deeper remission in the long term. So if you have a 3-month value of say more than 10%, you didn't achieve a EMR, then your chances of achieving MR 4.5 is just 20%. So it's very low. And you probably, if your goal is to achieve a deep molecular responses, probably it's you need to act on this. Similarly, the more time you take to achieve the deeper length of responses, your chances of achieving a deep molecular responses goes down. So this kind of predicts what are you going to achieve at long-term interval based on the early responses. And similarly, you can see here that the achievement of a DMR MR 4.5 at different EMR levels. So at 3 months, if you achieved EMR, your chances of achieving is 30% as opposed to less than 10% if you are not achieved that. Moving on, so EMR failure is different across the different so-called subtypes. So if you have a high risk so-called, and this probably is true for other scores also, your chances of not achieving MMR goes up. So this is less than 10% with nilotinib, and this is more than 30% with imatinib. So at this early time point, you could see the difference in terms of activity of a second generation TKI versus first generation TKI. And what is shown on the graph on the right side is that if you use a stronger TKI, the difference between the low, intermediate, and high risk goes down. So for example, imatinib retains a difference of 20% versus say 40%, but in terms of nilotinib, the difference is 7% to 10%. So this difference of achievement of EMR sort of narrows down if you are reaching a potent second generation TKI in the upfront setting. I spoke about the importance of kinetics and halving time. So this is really useful for our patient where we don't know whether they actually have a higher disease burden to start with. And a 3-month value maybe, if it is just about 10%, you would be classifying this patient as failing a very important time point. But this study shows that rather than a single value, the halving time is very important. And in this study, what they showed is that if your halving time is less than 76 days, you are good. If it is more than that, then you probably are not as good as you are in the other subset. And this is shown in their clinical outcome data. So overall survival and progression-free survival, if your EMR is not achieved, but your halving time is less than 60%, it is as good. So rather than a single time point value, it is important to look at kinetics of this response assessment time point. Now we'll move on to before we move on to the other endpoints, there are following issues with EMR. All these are post-hoc analysis in studies. There are limitations of current methodology as well as estimation is concerned. The overall survival in RCT is comparing imatinib versus second generation TKI is same. So we don't know whether this would really pan out in this smaller niche area. And impact of change of therapy at this time point is really not clear. We move on to MMR, and this is important landmark point. And as you could see that MMR achievement. So this is again from CML4 study. If you achieve MR, your overall survival, progression-free survival, MR4 and MR 4.5 is better. But these included patient who had MMR, be it with cytogenetic response, without cytogenetic response. So definitely there are going to be interactions as far as other endpoints are concerned, but definitely achieving a MMR is important. And if you are monitoring a patient only with PCR, then you should vouch for this endpoint. A bit of data from decisions from MD Anderson, and what they tried to show is if you have achieved MMR, or if you are not achieved MMR, but if you are in complete cytogenetic response, your outcomes are same. So this highlights the interaction of a cytogenetic response and a further molecular response. So this is one thing you have to keep in mind. And as we saw from the previous panel discussion, different weightage given to MMR in the ELN versus NCCN guidelines probably reflects a bit of ambiguity as far as MMR concerned. The next time point is deep molecular response. So it is important for achievement of TFR, and what we see is if you have achieved MMR, your chances of achieving DMR goes up. And this again probably is shown in the different way in the CML4 study, where what they have shown is if you are not achieved MMR early, your chances of having a DMR in long term is less than 20-30%. And if you have achieved that, your chances roughly doubles. So if your goal is to achieve a DMR, then probably sticking to early time points very religiously and attaining them is important message to go behind. And this can be seen from both Einstein and Decision study that achievement of deep molecular response is more with second generation TKI. And by 5 years, you could see that the difference is roughly 15 to 20% in the Nilotinib study, and it is slightly around 10% in the Decision study as far as the deep molecular response is concerned. So it doesn't give us that much of advantage, but definitely there is an advantage in terms of achievement of deep molecular responses. We'll see some of the Nilotinib study with this background, and the Nilotinib is approved in adults as frontline and second line treatment, as well as in pediatric patient for first line and second generation treatment. And we will see some of these studies. So frontline study, Einstein, very famous study comparing imatinib to nilotinib head to head, and done in more than 800 patients. And there are nilotinib studies in second line as well. And there are studies of nilotinib looking at the possibility of TFR right from the beginning. So if I use nilotinib at the diagnosis, so Einstein freedom data, and for person who is on imatinib but not qualifying for TFR. So we'll see some of this data. So in Nilotinib study, Einstein very familiar to all of us, randomized patient into imatinib and 2 different doses of Nilotinib 300 and 400 BD, and the results were published at 5 and 10 years. Results are available as of now. So as you can see, the MMR rate in the 1 year time points are roughly double as compared to imatinib, 22 versus 44%, speaking of the depth of the response. Not only MMR is achieved, but it is maintained. So difference is approximately 15% at end of 10 years. So these responses are long lasting. We look at the DMR and its utility because of the treatment-free remission, and the difference is even wider. So here it is roughly 20% difference in terms of achievement of a deep molecular response versus imatinib. So this is roughly 40% and 60%. So this is again a reassuring thing if your goal is to achieve a DMR. When you look at the event like accelerated phase and blast crisis, we don't want our patient to develop that because it's difficult to salvage. And you could see that these numbers are very small given the excellent outcome with TKI, but numerically the numbers are less in the nilotinib arm as compared to imatinib arm. And when you look at the death because of the CML, the death in the CML in the imatinib were 21 as compared to 10 and 6 in the other two arms. So fewer patients died of CML as compared to this thing. But what if you could see the development of APBC in the initial part of the study as well as the later part, so the effect is maintained throughout. Not only nilotinib is effecting in preventing early progression, but even in long run, it has less incidence of AP and basic transformation as compared to imatinib. What we are always looking at is overall survival. The overall survival is not different as compared to imatinib and nilotinib, and this is the potential of the drug is there demonstrated in terms of depth of the response and rapidity, but it is difficult to show given the excellent outcome with imatinib. But CML related death, it achieves significance as far as the CML related survival is concerned. One important thing is you have equivalent overall survival, but if you have a more efficacious drug. So what is happening there is, are we losing patient because of the side effect? So this is important question. And if you see nilotinib, you want to know about cardiovascular side effect, and definitely the cardiovascular side effect, if you focus on grade 3, grade 4, they are more in nilotinib arm, both the arms, and it is 5 and 13%. So definitely this is there. You could risk stratify patient and see that you could have Framingham score low, intermediate, high, and it is mostly in the high risk patient but still you would have some difference in the low risk cardiovascular patients. So definitely cardiovascular mortality side effects is a concern, and that has to be factored in decision making. We'll move on to second nilotinib study, where a patient was switched from imatinib to nilotinib with the aim of improvement of MMR, and this is done when patients were treated and they had achieved CCR, but they were not in the molecular remission. So they had some detectable BCR-able. A small study of 200 patients and randomized to continuation of imatinib same dose versus nilotinib 400. What you could see is there is improvement in the CMR rates, roughly 5% to in the imatinib continuations to 10%. So this gives us a bit of advantage if you switch from imatinib to nilotinib if you want to achieve a complete molecular remission. But the difference you have to keep in mind, and the drug, the side effect, the cost, etc. will have to discuss with the patient. Similarly, the incidence of MR 4.5 was also increased. So this is relevant in terms of TFR, and it's 47% and 37%. But what this small boxes represent is patient on the imatinib who were given nilotinib. So actually the difference is slightly more. So you could expect that you would be able to push 10% more patient into MR 4.5 and make them eligible if you are switching one patient from imatinib to nilotinib in the first line setting when someone has not achieved complete molecular response. There is some data in pediatrics, and this is a recent data of less than 100 patient given as upfront or when they were resistant or intolerant to imatinib, and you could see the MMR and MMR rate at 6 and 12 months respectively. So this drug is has some data there also. We'll move on to TFR studies, and there are two studies where I will like to this one. One is instead freedom study. So what happens if you use nilotinib upfront and do an attempt TFR? And next one I will like to see is instant stop, where patients were given imatinib and they were not eligible for TFR, but they were given nilotinib for 2 years, and then what happens to their TFR rate? And this is probably one practical question every day we face: should we change our patient to second generation TKI for TFR? So this is the instant freedom study, where patients were given nilotinib as a first line therapy, and what you could see is the TFR rates are at a fairly long follow-up, so 192 weeks, that means 4 years is around 50%. So that's reassuring. It is as good as imatinib given, and all the TFR imatinib study correlates. And most of the patients who had lost their responses, the kinetics and responses were similar what we see in the imatinib TFR study. So there is data for TFR in post nilotinib setting. The achievement of responses after restarting the drugs are rapid, as is case with imatinib. So most of these patients will achieve MMR and DMR. Most of these people will have this time point achieved within less than 3 months and 6 months respectively. So even if you lose your patient loses TFR, he loses MMR, he is going to go back to his treatment condition originally he was on. We move on to NS stop study, where patients were given nilotinib with the aim of making them eligible for TFR. And what you could see is when these patients become eligible for TFR, the success rate is same. So this also speaks that even though you are taking a slightly registered patient population, but if you could achieve eligibility for TFR by switching on to second generation TKI, your outcomes are equivalent. So that's a bit of support for changing patient if you are keen, but this is a small data, and this is slightly divergent with current ELN recommendation. Current ELN recommendation doesn't recommend anything, but they say you should discuss with patient, or it is an individualized decision. And similar to the Instant freedom study, the achievement of response prior to stopping the drug in case they lose is fairly rapid. So in summary, nilotinib leads to early and deeper responses in patients with CML if they are treated upfront. MMR, DMR rates are higher and they persist throughout the follow-up period, but the overall survival at 10 years, a fairly long time period, is similar to imatinib. It lowers the risk of progression to AP and BASI and CML related death. It is associated with some toxicity, and that you have to weigh from individual patient to basis. And TFR following this nilotinib either upfront or switching after using imatinib is feasible. So as to give chance to other second generation TKI, so this is sort of a summary slide where I have put Dasatinib, Instant and before data, looking at Dasatinib, nilotinib and bosutinib respectively when they were compared head to head with imatinib. So what you could see is there are different variable period of follow-up, and the numbers may look different. But in each study, as compared to imatinib arm, the rates of EMR and BCR-ABL 10% at 3 months are higher for second generation TKI as compared to imatinib, but the event-free survival and overall survival doesn't change. So if you are using second generation TKI, you should be clear what you are going to get by using these drugs upfront. Important thing is, if I use second generation TKI and if patient fail, what am I facing? Is it a big problem? So important, and I think a fairly easy thing is for second generation TKI or a second line treatment, the monitoring and the time points or the evaluation guidelines are same, and the definition of failure remains same. So that makes it uniform. This is slightly different from the earlier ELN 2013 version. When you have a person who has failed second generation TKI, it is important to look at some considerations of how patient's comorbidity, what mutation, TKD mutation patient has. Does he have a suitable donor for transplant? Because we are looking at failure of a second generation TKI, and we have different options like second generation TKI or ponatinib or a transplant or a clinical trial wherever it is available. With this, we move on. So one important thing, when someone has failed second generation TKI, it is important to distinguish between the resistance versus intolerance, because resistance has a different outcome or connotation as can be understood as compared to intolerance, and failure in the first line versus second line setting may have different connotations. So it is probably reasonable to think that earlier failure may represent a worse out situation than the failure in the later line of therapy. On failure, we also need to understand what's the mutation patient has developed, what is the comorbidity person has, and what's the prospect of allogenic stem cell transplant whenever we assess second generation. And there are other there is a question of using the other second generation TKI, so that may be nilotinib or ponatinib depending on what you have used, versus a third generation TKI ponatinib, and probably a TKD mutation analysis will help us, and we'll see some of the data to this effect. So surprisingly, there is very little data on what happens to patient when they are treated with other second generation TKI when they fail one second generation TKI. So this is a summary table from one of the recent publication in leukemia, and all these studies have patient less than 100. And you could see that the achievement of complete cytogenetic response and MMR rates is pretty low. So if you see all the studies, the upper, except for the lower one, it is less than 35%. So chances of second generation TKI working is probably lesser as compared to a imatinib failure, and this probably is because of the resistance developing in presence of a very potent therapy. This is one publication where bosutinib was used as a third line, and these people had a higher rates of CCYR 84% and 64%, and let's see what this study was. So this study was beyond study. This has been presented in abstract form. Full text is not available as of now. This treated 153 patient who had a CML CP patient who had a failed second generation TKI, and in this patient 80% of the patient achieved complete cytogenetic response, and intolerance versus resistance. So this complete cytogenetic response in these categories were the same, but MMR rates were higher in patients who were intolerant as compared to resistance. And you can see on the right side, the MMR rate, they're ranging from 80% to 56% when you are failed after first, second, or third line of TKI, and MR rates also. But this is a bit of assuring that you could try a second generation TKI if you don't have option and you don't have guidance based on a TKD mutation analysis. We move on to the next drug, ponatinib, the third generation TKI, and this is from the PACE trial, the 5-year result. And what you can see is in this patient of CML CP who have failed second generation TKI, the responses in terms of major cytogenetic response is roughly around 60%. CCOR rate slightly lower than that, MMR rate maybe 10% lower or that. So these people have responses. But what is shown in the graphs at the bottom is if someone achieves a response, so if they respond, then the responses are long lasting. So duration of major cytogenetic response, if someone has achieved a major response, it's more than 80% at a 5 years. So if someone respond, that is good, and he is going to maintain that. And similarly, the major molecular responses also, the maintenance rate is 60%, and this is fairly refractory population. So this is a bit reassuring as far as this drug is concerned. But the problem is with the side effect, and because of that, the study was halted and this study came up. So this is the OPTIC study, where this is a phase 2 study. They use 3 doses of ponatinib, and they used 45 milligram, 30 milligram, and 50 milligram in 3 cohorts. In cohort A and B, they plan to decrease the dose if you have adverse event or BCR-ABL falls below less than 1% to 15 milligram. And by doing this, they could decrease the dose in 75% of the patient in the cohort A and 88% in the cohort B. So almost every patient who was started on higher dose who achieved a response could be dose reduced. This is fairly large sample size of n equal to roughly 300, and you have a complete cytogenetic response rate roughly 30 to 40% in this population. And MMR rate in the 3 cohorts are 14, 15, roughly 15 to 20% of the bracket. So what this tells you that though the drug is toxic, probably dosing is something which we have to work on. And this is one important message if you want to use ponatinib in your clinical practice. This is a abstract being presented at this ASH meeting, and this is a combined data of PACE and OPTIC, where they have compared the patient of PACE at 45 milligram versus OPTIC, where 45 milligram was decreased to 15 milligram. And what they are trying to show is the responses are maintained. So roughly 40-45% responses in the both group. The PFS at 2 years is roughly 67% in the PACE group, the earlier report of the study, but it is slightly higher, and this is probably you are able to give this patient drug for longer time of period. Overall survival at 2 years is 85 and 93%. So this will be interesting. What happens to this drug? Are we learning better how to use this drug? This is again in terms of side effect clearly reflected that the serious adverse effects were half if you have this dosing, so 30 versus 60% roughly. So this is a bit of assurance. If you want to use ponatinib, probably a lower doses is important. So this dosing issue, it will depend upon what the phase of the patient is when you want to use this drug, and what TKD mutation the patient has. Also the patient's ability to handle the drug, especially the cardiovascular risk factors. We can start low and maintain low dose, giving the optimal response and adverse event. And this might be true for CML CP patient with comorbidities and not having registered mutation. But in patient where the risk of failure of the drug is high, for example, some certain mutations or advanced phase, probably starting at higher dose and then decreasing may be a sensible thing to do. The responses to ponatinib are very quick. So you come to know at the end of 3 months that whether you are achieving MMR or CCYR, and you could decide for dose escalation. So that's one thing to guide your further treatment beyond 3 months. Finally, considerations for allo-SCT. Since we are failing second generation TKI, probably this is the time to think of allo transplant, and early referral assessment of risk of transplant is important, and a preparation at the failure of second generation TKI. This is probably the best time to refer to patient. We'll have to evaluate the transplant versus CML associated risk, and this will be like patient related factor, for example, age, comorbidities, type of donor, etc., etc. And you, in terms of transplant, you look at TRM and GVSD, and there are different tools to get an idea of TRM and GVSD. And in terms of disease related factor, you have factors like current phase, the TKD mutation, or additional factor like ACA. We were discussing in the panel discussion about the prognostic implication of ACA, and some ACA, they call it class 1 in that German paper. They are really bad, and they have a very strong suggestion to proceed with allogenic transplant in this patient. But it is important to send patient for transplant in a chronic phase and a disease controlled, rather than sending him when all the TK have been exhausted and disease is uncontrolled, or patient is not in cytogenetic or maybe hematological remission for that matter. There are other options when person fails this drug and ponatinib allo-SCT is not available. So interferon alpha in a chronic phase, there are older data, and you could try in your individual patient. Clinical trial, if available, is important thing. Thus, data with asciminib looks promising. The last year's NEGM publication, but we'll have to see more data on this drug coming in the near future. So I will conclude by saying that second generation TKIs are potent, and they lead to earlier and deeper responses. Overall survival with the use of second generation TKI is similar to imatinib, and this is possibly because of the treatment emergent side effects. So one has to be thoughtful while choosing first generation versus second generation TKI. Failure to second generation TKI, as of now we have limited data, but we have some salvage options available as of now, and a bit of clinical judgment is required on an individual patient basis for choosing these drugs in the management of CML. So with this, I will stop, and I will thank everyone for giving me this opportunity. Happy to take questions if required.
Thank you so much, sir. We've not received any questions. So with your permission, I'll move to the next session.
Sure. Thank you.
Yeah, thank you so much, sir. Our next session, the academic session 2 on newly diagnosed CML and CP. Our moderator is Dr. Pankaj Malhotra, hematologist from Chandigarh. His panelists are Dr. Sadashivdu Gundeti, medical oncologist from Hyderabad, Dr. Mehboob Basade, medical oncologist from Mumbai, Dr. Ganesh Jaishatwar, hematologist from Hyderabad, Dr. Shweta Bansal, hemato-oncologist from Mumbai, Dr. Lalit Kumar, medical oncologist from New Delhi. Pankaj sir, please note, Dr. Sham is not able to join us. Over to you, sir.
Okay, all right. Thank you very much. And thank you to the organizers and especially Dr. Advani and Dr. Parekh for organizing this very, very important meeting uh, and, making me a part of this meeting. So you have been listening to chronic myeloid leukemia from the diagnosis, from the monitoring of chronic myeloid leukemia, Dr. Vikram Mathew, and later on, second generation TKI from Dr. Bhausab in CML. So now we are going on to the panel discussion, which consists of newly diagnosed chronic myeloid leukemia and chronic phase. And the panelist, as has already been said, Dr. Sadashivdu Gundet, who is head of medical oncology at Nizam Institute, Hyderabad. Welcome, Dr. Sadashivdu. Dr. Mehboob Basade from Mumbai. Dr. Ganesh from Hyderabad, Dr. Shweta Bansal from Mumbai, Dr. Shyam Agarwal could not join because of some reason, and Dr. Lalit Kumar from AIMS Delhi. So we actually have not made too many slides. So what we would do is we take a case of chronic myeloid leukemia in two situations, and we'll take opinion from from all the panelists, and maybe can ask Lalit Kumar as a senior oncologist and senior person in this country to give his final opinion. So the cases, we have two scenarios. We talk of a chronic myeloid leukemia chronic phase in a 40 years old gentleman, and we can generally most of us do a SOCAL scoring, and whether it is low or high, and this patient does not have any comorbidities. So if I go serial wise, the choice of first line TKI and its dose, and why do you choose that? So Dr. Sadashivdu, can I ask you first?
Yes, sir. Hello?
Yeah, we can hear you.
Yes, sir. I think there's always, whenever we choose a first line TKI in a newly diagnosed patient, first we'll do this scoring system. Because we have the first generation TKIs and second generation TKIs. So we can choose that treatment modalities based on the patient comorbidities and risk scoring system and preferences, patient preferences. Ultimately, we should get the best response, and at the same time, the response should sustain longer. And our long-term goal is always nowadays we are talking about the TFRs. So with the lesser toxicity and less financial toxicity also. So we have to take into everything into consideration in Indian context. So we have to just choose the best medicine with the least toxicity, and that remission should sustain longer. So with that, we have to go for the scoring system properly, and comorbidities also we have to think in terms of side effects profile of each drug.
So what do you choose? This is a practical question that this patient, if it is a low risk SOCAL or high risk SOCAL and no comorbidities.
Still, if it's a low risk SOCAL, I'll go for only imatinib, because it's a well-known drug. It has a good side effects profile. We know how to manage the side effects. Low risk, I'll go for imatinib. If the high risk, I'll go for the second generation TKIs. Again, in the nilotinib or dasatinib or bosutinib based on the patient comorbidities.
No, there is no comorbidities. No comorbidities. Yeah, so we are talking of a situation.
Yes, I think because of the cost is the major in comorbidities. There no comorbidities. Definitely, I'll go for this. Dasatinib is the first one because available in generic forms. Definitely, this is cheaper. Definitely, I'll go for this dasatinib, sir.
Okay, so dose of imatinib?
Yeah, dose I still I'll go for only 400 mg.
400. And dose of dasatinib?
dose of Dasatinib, now we are going for 100 mg per day.
Okay, because there is,
CML
one paper from MD Anderson which suggested even 50 milligram Dasatinib is good, and there is a lot of hype about that. So have you changed your practice to 50, or you still feel that 100 milligram is the optimal
first
dose?
I'll go for 100 only because we want to get the maximum response. But if patient develops any complications, I think definitely we can break down the doses. Some of the patients, they are maintaining only 70 mg, 50 mg also we are giving continuously, we are giving that one. So based on the toxic, but still for the first choice is 100 mg we are using.
Okay, so if I can summarize, so if you would do the Sokal scoring, and if it is a low Sokal score, you would go for imatinib 400 milligram. If it is a high Sokal score with no comorbidities, you will go for 100 milligram Dasatinib as your first line. So this is the summary of what you have said.
Yes,
okay, we go to Dr. Mehboob. Dr. Mehboob, please.
Yeah, Pankaj. Hi, good evening.
Good evening.
Yeah,
welcome.
I agree with Sada also that in low risk now we have an option of second generation Dasatinib at a cost, as he discussed about the cost. So imatinib and low dose of 50 milligram of Dasatinib is equivalent cost, because I would choose second generation Dasatinib over the first generation, not only from the good response point of view, but also looking that the duration required for TFR to be eligible is 4 years compared to imatinib for 5 years. So even looking from that perspective also, that I would like to use the second generation Dasatinib. Sorry, second generation in the low risk. And the high risk, obviously there is no question. We have to go for this the second generation. And again, comorbidities, always we have to look.
Yeah, here we are talking of where patient does not have any comorbidity. So what I understand is your choice is also the same as with the Dr. Sadashivdu. Okay, Dr. Ganesh.
Good evening, sir.
Good evening.
Thank
Welcome.
you so much, for honoring me with this role. And if I'm excused, sir, please, can I just keep my audio on? I'm traveling, so if I keep my video off, is it?
Sure. No issues.
So as my previous colleagues have elaborated the choices, and as per the previous talks, the comorbidities, the cost is of course not at all an issue nowadays because of the generic Dasatinib and even the Nilotinib also with the patient assistance. The cost near about comes almost more or less equal. But looking at the overall, when we have the point elaborated by previous speakers that OS and PFS is going to be same, because once one first generation TKI fails, we have the choice of, and that happens in the clinical practice most of the time. So why to take that chance? And for patients less than 60 years of age without comorbidities, second generation TKIs will be the preferred choice, of course, above the age of 60 years because of higher cardiopulmonary toxicity with second generation TKIs. Imatinib in low risk groups still may be an option, and I'll be intended to opt for second generation TKIs even for ELTS or so-called intermediate high risk, even in the elderly admission until there is an absolute contraindication, because apart from the achievement of earlier deeper responses, the chances of transformation are quite low. And in our set of patients, almost 40 to 50% patients are below the age of 45, quite younger. And many of our patients, contrary to the Western literature, fall into the intermediate and or high risk scores, whether ELTS or focus. So preference, because cost is not an issue, and most of the younger patients, TFR is a realistic and is a practical goal. So the moment we start the medication and counsel, do the first counseling with the patient about the necessity of continuing the drug lifelong. Initially, with the trauma of that blood cancer, they will accept. But over a period of time, after 6 months, 1 year, once we keep on, discussing the various the therapeutic milestones, deeper molecular remissions, the next question invariably asked by most of them, irrespective of age, sir, how long? So that's a very valid question, particularly for a country like ours, where all of our patients end up paying out of their pocket. So preference, unless and until absolutely contraindicated, will be for second generation TKIs. And Dasatinib doses, of course, there is a very nice paper by MD Anderson, but then that's a single center experience with a shorter follow-up, just 1 year. Of course, the preliminary results are very promising, but unless and until the tolerance or other issues are a problem issue, because the cost is more or less same. So definitely start with 100 milligram, and unless and until the tolerance or the complications toxicity is an issue, we will not just start with 50 milligram. That is not as of yet a standard of care across. Thank you.
Okay, so what I understand from Dr. Ganesh is you have talked about the problems which are faced when you are initiating therapy. But what I understand from you is even for low risk, you feel that you want to start with the second generation in a young patient. That's what the summary is.
Yes, sir. Low risk, less than 60 years of age, I will start with second generation.
Second generation. Okay. So now we go to Dr. Shweta Bansal, who actually has done compiled the issue on chronic myeloid leukemia, collected all the data from India and compiled it and came up with an issue with Dr. Purvesh Parekh. So Dr. Shweta, what is your view? And you can also comment a little bit on the pediatric CML also.
Thank you, sir. So I'll mainly comment on pediatric CML, though I have collated the data with Dr. Purvesh Parekh and Dr. Kumar Prabhash when I was there in Tata Hospital. So whatever the experience in pediatric CML and in the patients who are younger age with low SOCAL score, I mean, the data is, the long-term data is more in favor of imatinib. Most importantly, what we are understanding nowadays is that with the CML, when we are embarking on the treatment of CML, what we are trying to achieve, whether it is a treatment-free remission or we are going to have a deep molecular response. So, I mean, the discussion with the parents and the patient is very, very important. And depending upon our goal, the choice of TKI should be there. And also the considering how regularly the patient can follow up with us. So considering like in my practice, I mostly prefer imatinib to use in younger patients with low SOCAL score, because one is that the patients, they don't want to come regularly for a very regular follow-up. When we are using a second generation TKI, more regular follow-up is required for these patients to rule out the toxicities which are associated with them. And definitely the cost issues are also there. And other thing which I always feel is that once we are over with one of the TKI, there is always a choice of another TKI to be used in these patients. So my always preferred choice in these patients is imatinib. And there is no data which can suggest there is a overall survival benefit of using another second generation TKI. So imatinib is always a better choice.
I think, I think that's a very, very important point which you have raised. And before going on to Dr. Lalit, if I can ask all the other four panelists, and as Dr. Shweta also said, there is no survival benefit. But Dr. Ganesh said, we are now looking at the TFR in many of these patients, and that's why you want to start with the second generation TKI as upfront. But let me ask this question to the four panelists. We know that 800 milligram of imatinib or 600 milligram of imatinib achieves the same response as with the second generation TKI. So, and as Dr. Shweta raised a question that if you use imatinib, patient develops resistant, and we know that 50 to 60% of patients actually will change their therapy by 5 years time. So that means at 5 years, half of the patients are going to switch to the next generation. So if you use imatinib, you always have a choice on dasatinib and nilotinib. Whereas if you're using dasatinib, probably I don't think so in your practice you will go back to imatinib. So let me ask those four panelists one by one, Dr. Sadashivdu and Dr. Ganesh, Dr. Mehboob, and so ask these people what is their viewpoint on using a higher dose of imatinib if you are really thinking of achieving a MMR equivalent to the second generation TKI, before going on to Dr. Lalit.
Yes,
Dr. Sadashivdu.
Yes, sir. I think this we have some studies suggesting of 600 mg or 800 mg. Definitely, we can get the same response as the second generation TKIs. But problem in another context is most of them, they may develop side effects. The side effects profile is a little bit different. Sometimes with the side effects, again, they will drop down the dose, they will skip the dose. Ultimately, again, that we are unable to maintain the dose intensity. So discontinuations are a little bit higher in the high doses of imatinib. With that, I think that my intention in this one is we will start with imatinib. We'll follow them regularly, a third month or sixth month. With nowadays, we are able to do this BCR ABL very cheaper in an institute level. If I get any something suboptimal or suboptimal response or something, definitely I have the choice of dose hike. I have the choice of second generation. But still, what you said is correct. The response is we are going to get 600 with the 800 or better with this as a second generation, but tolerance is a major issue, sir, in our setup.
Okay, thank you, Dr. Mehboob. So do you think the we all agree that imatinib is the most safest of all? I hope you agree with that statement.
Yeah.
So do you feel that a higher dose of imatinib will have the same side effect as the side effects of dasatinib 100 milligram?
In my practice, what I found that those patients who are on the higher dose, the compliance has been an issue. They all the time say that there are a lot of issues if you take 2 times the imatinib. And that's where now I have shift because with the availability of the cheaper version, generic versions, now I am asking them to go to the second generation because of the compliance issue. And I mean, I'm sure that there are many patients from everybody's practice that compliance is an issue. And obviously the toxicity is there, which is more than 400 milligrams. There is no question in that. And again, the second question which comes when the patient walks in and we tell them that this treatment is going to be lifelong, and they are say that, oh, can I stop it after 4 years, 5 years, or what it may be. So if you go by the ELN criteria, they say that if you use second generation, you can look at least for 4 years. After 4 years, you can start looking for it. So even, and if you are using imatinib, that first generation, you have to look after 5 years. So even there is 1 year concession if you are going to use the second generation like dasatinib or for that matter. So both ways, I feel that rather than going on the higher dose of imatinib, which may be now effectively expensive compared to the second generation.
Okay, okay. So you made your point. Thank you. Dr. Ganesh, quick point before we go to Dr. Lalit.
Yes, sir. So as such, starting imatinib, you mean to say 600, 800 upfront, sir? In CML
Yeah.
CP?
So my question is that when you are talking about 600 or 800, you always talk about the tolerability of higher dose of imatinib. But the question is that dasatinib also have a tolerable issue. Nilotinib also have a issues with the tolerability. So why not give a higher dose of imatinib rather than starting second generation TKI as upfront? Because after starting dasatinib or nilotinib, if the patient develop resistance, you have limited choices. If you start on imatinib, you still have more choices.
Yes, sir. So just I will try to quickly sum up the first of all, continuing imatinib 400 itself is as toxic as, of course, the toxicity profile is different. The imatinib toxicity, the fluid retention, the myalgias, body pains, fatigue, and somehow relatively low hemoglobin compared to dasatinib or nilotinib. So that 400 itself is on a long-term basis. If we have to continue at least for 5 years, if we are realistic about TFR in younger patients at least. So on top of that, continuing 600, 800 to our experience and practice, limited practice, is a real challenge. Very few patients tolerate. Most of them end up with symptomatic anemia, severe toxicity compared to the second generation TKIs. Of course, even there is a European, I apologize, there is a paper where imatinib 400 suboptimal response or failure to achieve the therapeutic milestone, then compared to second generation TKIs, imatinib dose escalation was significantly inferior in terms of all therapy.
Yeah, that is a different situation. We are talking of upfront
the tolerability is a big issue.
Okay,
Again,
okay, you made your point.
Yes.
So Dr. Ganesh, you made your point. Thank you. So Dr. Lalit, first is, sir, can we see your video? Your only forehead is visible, sir. We want to see you. We want to see a smart man and pay our regards to Dr. Lalit. Dr. Lalit, please, if you can just video, sir. If you can just
Yeah, actually, I'm trying to.
Okay.
So
Dr. Lalit, you are the most experienced and you have seen CML, going on from, interferon era, busulfan, hydroxyurea, interferon, transplant, imatinib, dasatinib. So your
Yes,
is the
Pankaj,
final word.
Pankaj, there are two points which I think I agree with most of the panelists.
Okay.
That the patients who are young, like 40 years old, with low SOCAL score, I think in our practice, we still use the imatinib as a 400 milligram daily dose. Nowadays, in last 2 years, we have started discussing about the second generation, but I would say like 80% probably find it difficult. Maybe 20% patients do agree for the nilotinib or dasatinib. And in such situation, when we have to use then I generally prefer the dasatinib 50 milligram per day. But then there's some patients who are on the nilotinib, but need maybe less than 50 patients. For patients who are the high SOCAL score, we generally try to emphasize on more on the second generation TKI, again the dasatinib versus nilotinib. But then practically most patients find it difficult to continue on they have to do for the long-term basis. Now, so that is so that's what I agree with the most of the panelists in that regards.
Okay, but you said 50 milligram dasatinib as upfront, so you want to follow the MD Anderson data.
Actually, 50 milligram.
Yeah, so one, I think most of the people who are treating CML, they know that, in their usual practice, dasatinib, giving many patients are actually on 50 milligram or 50 milligram 5 times a week. And some patients are actually on 20 milligram also. But these are all those patients who have received imatinib as upfront, and after the failure of imatinib, they are put on, dasatinib. So in those patients, definitely the dose, many of these patients actually do not tolerate the dose of 100 milligram as upfront, whereas newly diagnosed patients can tolerate the dose. All right, thank you, sir. And
I
just
don't really have the data
yeah.
on the 50 versus 100 milligram like any large data. It's only small number of patients in the last 6 months when the generic plants became available, so we started using it. But we have treated probably nilotinib about nearly 50 patients or so. But majority of our experience with the imatinib only. And we have done about 69 patients TFR, but we have, after 5 years, we have stopped the imatinib, and we have nearly 44% of them, they continue to remain in remission at the end of 1.5 year follow-up.
Okay, that's a very, very useful information which we have given, sir. And maybe if Dr. Advani is there, and sir, if I can take your opinion, although, officially you are not the panelist, but you are the, panelist of panelists. So Dr. Advani, if you are there. Okay, maybe he's not there. So the second scenario is actually of a 65 years old gentleman, and here this patient has comorbidities, which we know after 60 years of age, almost 60% of our patients have comorbidities, either in the form of hypertension, diabetes, or something else. So quickly, the choice, we have only 5 minutes. So from Dr. Sadashivdu.
Yes, sir. I think already we have discussed the same way. Based on the comorbidities, we can choose the first choice of the drug.
Here you would still choose, think of second line TKI, or imatinib is your first choice?
It's a low score. Definitely, I'll choose only imatinib. There is no doubt in that.
And if it is
high score, I think I'll convince the patient. But problem here is the patient is having the all comorbidities: hypertension, diabetes, AIDS, COPD, or one by one. I don't know, but you have mentioned everything. If all these are there, I think I'll choose only imatinib.
Okay.
So if it is only one diabetes is there, I think I'll try to avoid the nilotinib, because nilotinib will cause a hyperglycemia. If the patient has something, for example, pulmonary diseases like any pulmonary problem, I'll try to avoid the dasatinib. Okay, if the patient has something hypertension, the CAD issue, CAD coronary artery disease with QT prolongation, I'll try to avoid the nilotinib. And so everything is individualized, and based on this comorbidities, we can choose the therapist. But still, low risk, we are comfortable with the imatinib as well as sir said, other people also. We have
Okay.
enough experience in that. Yes.
Okay.
Now we are
Dr.
able to monitor.
Yeah.
We are able to monitor the response very strictly, stringently. So if you have any problem, definitely we'll change it to another agent or. So my choice is same, sir.
Okay. Okay. Thank you, Dr. Mehboob.
Yeah, for the low risk Sokal, I may go with the imatinib, but with the high risk, I will go with the bosutinib, because bosutinib is one of the safest probably with the cardiac and diabetic related, provided that the kidney and GI tract, there are not much of comorbidities associated with that. If GFR somebody is having less than 30 and having a lot of GI complaints, then probably even bosutinib also will be an issue. But otherwise, if those are not there, which are not been quoted over here, so if this fellow has a high Sokal score, I will go with the bosutinib.
And the dose of bosutinib upfront, which you are going to use?
400 milligram.
400 milligram only, and not 500 milligram.
No, 400.
Okay, okay, okay. That's great. Dr. Ganesh.
Hi, Lalit.
Sir, elderly comorbidities, low risk, imatinib. Again, as Dr. Mahbub sir has elaborated, I will be intended to add bosutinib if dasatinib and nilotinib is absolutely contraindicated. Or for that matter, I might even try dasatinib low dose 5/7, 50 milligram. With a, again here, again Tfr is again more realistic goal, because elderly population, durable, long-term sustained medication, again, a lot of issues. For intermediate and high risk, I will prefer second generation TKIs based on the comorbidities, as my previous esteemed panelists have elaborated: diabetes, hypertension, coronary heart disease, coronary artery disease, or the GI issues. Again, if cardiopulmonary toxicity already comorbidity is there, then bosutinib, or else low dose dasatinib or nilotinib based on the toxicity the comorbidity pattern.
Okay, thank you, Dr. Lalit sir. You anything to add here?
I think in this case, probably I'll just simply go the imatinib, 400 milligram per day, because that I feel is the more safest in terms of more toxicity and other things. That is what, irrespective of the Sokal. That's what generally we practice.
Right. Thank you. So we have 3 or 4 minutes. So Dr. Ajay Bapna is, want to make, Dr. Ajay Bapna, do you want to make some comments here?
No, actually I have written in the chat box whatever I have observed.
Yeah.
And, these are some of the new findings. And I was only concerned about the ethical issues of dasatinib 50 milligram, which Dr. Purvesh Parikh has sort of, have resolved that we can use it after explaining it to the patient. And secondly, as in continuation of Dr. Mehboob Asade's statement about the bosutinib in the second patient, there is a data for incremental or escalating doses of bosutinib, and looking at the transcript, every 2 months, and from 200, 300, and 400. So this is the new strategy to use in elderly with multiple comorbidities, the bosutinib. So these are the 2 observations I have made.
Okay, thank you. Dr. Tapan is also sitting here. Dr. Tapan Sekia, who is also one of the experienced person. Sir, if I can invite your comments also.
Sure. Pankaj, sure. Too many.
Yes, sir.
Yes. So the elderly person, all other things I agree. Probably for elderly person with so many comorbidities, even imatinib 300 should be good. If you look at the phase 1 data, the best results are with 300 milligram. Though they settle down with 400 milligram daily. So you have a data that even 300 would be good enough. There will be less fluid retention and other problems might be less. There are patients who are receiving 200 milligram. Plenty of patients, elderly patients, I suppose, they cannot even tolerate 400 milligram. Other second generations would be difficult for this elderly gentleman.
Agreed, sir. Agreed, sir.
Yeah. Dr. Sadashivdu, you had raised your point. You wanted to say something?
Yes, sir. With this, under hematology cancer consortium, I think all of us, we are going to just do the clinical trial on 50 mg of Dasatinib in CML patients. I think all of us, Lalit Kumar sir, all of us, we are in the part of that. I think this month we are going to start this trial, sir. Maybe once we have this data, definitely we can make it as some recommendation in the future. But Lalit sir is there here, I think.
Okay, so there is one question about the side effects of imatinib and whether somebody has seen arthritis as the side effect of imatinib. So if any of the panelists wants to comment.
I think this has been reported in the literature that very rarely you can have these kind of long-term side effects. So arthritis is one of the known actually.
So, okay, I can see Dr. Advani. Dr. Advani, we are talking of CML. You have been, looking at the CML for now, the most experienced person. If you want to make any couple of comments here.
No, I think everything has been really taken care of. The things have changed. Though initially we had very little choice, and today, because there's so much of the choice, so much of the technology, that we are able to really, get into the depth of it and apply the appropriate treatment. I think that's the most important advance, that you are able to choose the best treatment for a particular patient.
I think that summarizes this panel discussion very well, that if you have a lot of choices as a doctor, you have to see what is the best drug for this particular patient, appropriate medicine, start it and monitor it closely, and then go about this. With that, I thank you very much for all the panelists, and thank you, Dr. Advani and Dr. Purvesh Parekh, for giving me this opportunity to conduct this panel discussion. Thank you very much.
Thank you.
Thank you so much, sir. Thank you to all the panelists. We'll move on to the next session. Our moderator is Dr. Tapan Saikia, medical oncologist from Mumbai. His panelists are Dr. Amish Vora, medical oncologist from New Delhi, Dr. Gaurav Prakash, medical oncologist from Chandigarh, Dr. Uma Dangi, medical oncologist from Mumbai, and Dr. Ashay Karpe, medical oncologist from Mumbai. Tapan, sir, please note Dr. Bharat and Dr. Rakesh will not be able to join us. Over to you, sir.
Okay. Thank you. Kashish, thank you. And good evening, all panelists. We have a challenge here. Can you hear me?
Yes, sir, we can hear you.
Yes, sir, we can hear you, sir.
All right. Okay, we have a challenge here because 3 sessions got over, and there'll be now almost like an extempore questions and extempore answers. Because in the first diagnostic, Dr. Bikram Matthew touched almost everything. But still, we have a job to do. Let's share the screen and go ahead with... All right, the lessons. This given us the lesson for this one. So let's see what are the lessons we have. ELN CML 2020. The first table there was a diagnostic workup. Let's straight away go to the chromosome bending technique. All of you do chromosomal analysis in the beginning?
The karyotypes, sir, yes, sir.
Yes, all of you do it. Amish, you do it?
Yes, sir.
Gaurav, Ashay, you all do it,
Sir.
right?
Yes, sir.
Right then, there was a question Bikram Matthew asked, and then Bhau Sahib answered that question, that how many percentage of patients will have additional chromosomal abnormalities? 8% in German study. So it's not a very small number. So I think we need to do it, and because we can identify some of the patients right in the beginning. So do you get this kind of patients with additional chromosomal abnormalities in your practice?
Well, I haven't seen one, sir, yet, but I'm sure there are.
No, sir, I have also not seen.
Yeah, so at our center, sir, the bending part is because, the molecular results and tests are so readily available, the bending part is not usually done every time. So that is why probably we are not picking up those additional cytogenetic abnormalities which might be coexisting at the time of diagnosis.
But you do sometime, right?
Yes, sir. So that facility is available with us, and sometimes we do. Especially the role is we employ that more when we are suspecting development to accelerated phase, because one of the definition of accelerated phase is development of additional cytogenetics. So if we are thinking of more, so probably there, but it's not very readily deployed in clinical practice.
So, okay, let's talk about fish. Who does only fish but not chromosomal? So all of you do chromosomal banding, but fish, anybody uses for routine practice? Ashai, do you use it?
Yeah, sir. Actually, recently, there was one case. Basically, in PCR, where sometimes we use PCR specific probes. So there was one case which just presented with eosinophilia, and there was no other, like symptoms and other things were there. And actually, not done fish. And later on, when we did fish for BCR able was positive in 80%. So that was actually a learning lesson that whatever we are doing, I think at baseline we should be doing all the investigation like karyotyping to know whatever the additional whether chromosomal markers are there, fish is there, and also PCRs.
Okay, but if you do chromosomal banding and then fish for all, cost goes up, right?
Yes, sir.
Yes, sir.
And then of course molecular also if you do it.
I mean,
to be careful.
Dr. Vora here, Amish here.
Amish, yes, Amish.
Sir, normally in practice, patient comes suspected CML, we do bone marrow chromosomal banding and RT-PCR normally together. So if PCR qualitative comes positive, I normally don't get any chance to do fish. So I would like to know from all the panelists and from you, what a clear indication of fish?
All right, anybody is saying, Gaurav?
Sir, I think the only role is when we are not suspecting the major transcript and some atypical transcript and pick it up. We usually do not do at the time of initial diagnosis, because RT-PCR, if you test for both major and minor, is able to pick up more than 98% of the cases with this translocation. And so fish is only when you're thinking of atypical translocation, or for some reason, technical reason, the PCR is coming negative and the clinical suspicion is very strong.
Could you elaborate a little bit on that, what you mean by atypical translocation?
Sir?
Break apart basically, sir. Basically.
So I'm not a molecular scientist, but you know, the E13EA section, the break apart locations are different. And
in
PCR...
Fish. In fish. We are talking about fish at this moment.
Yes, sir. So if there is an atypical break apart area, so it may not be picked on PCR because that is primer specific.
Yeah.
And, so that is one location where the fish, which is a more broader technique, which is going to bind to a complementary sequence, which is a very long sequence. So that is one area probably if the clinical setup and the pre-test probability of CML is very high and our PCR is negative. Another is non-availability of PCR, which is now not the case.
Okay. So there is the insertion of the 922 translocation sometimes might happen not at the end, but in the interstitial part, in the middle of it. So fish can pick up.
Yes, sir.
Just
Yes.
1-2% of the cases.
So even if the break point is at 2%,
works very well.
It can pick up.
Yeah. So I think that when it's pH negative, BCR positive, you might like to have a fish sometimes because you might like to follow up with fish if PCR is for some reason not available.
Yes, sir.
Again, in the ELN 2020, they says there's no need for quantitative PCR. Do you all agree with that, Amish?
Yes, sir, completely. I always wondered that why are we doing quantitative when none of the definition helps us in the beginning of quantitative. With ELN 2020, I think this makes sense and I agree with that. Sir.
Okay, I will give you a case scenario. Anybody can answer. Someone, you do a baseline, your BCR able is only 12%. All right?
Yeah.
At the end of 3 months, you get 9% response. What will be your reaction?
So less than 10% by definition at 3 months is sufficient response.
So 12,
I know. So 12% to 9% is not, and there are some definitions that in 60 days you should have half of your value of BCR ABL. But at the same time, I have never faced a situation so far before ELN 2020, sir. I always went for quantitative and qualitative both. But I feel that this makes sense because whether it is 30%, 40%, if you achieve major molecular response or complete cytogenetic response, does it really matter quantitative at diagnosis?
So if you look at the range, it may start from 12, 13% to all up to 90%, 92% or 100%. You might get it. So there is a question. This question I did ask in many international fora. Nobody had answer to this one. So that's
I
why
don't have that answer.
That's why NCCN is, they say that you should have it. Probably ELN, see ELN is recommendation, it's not guideline. They say that this is recommendation. This is, we're not telling you that you are bound by this, whatever recommendation we give, you can individualize. So let's move on to the next table, which is about the score. So all of you use ELTS?
Yes, sir.
Yes, sir.
Each and every one of you using ELTS. Yeah. SoCal also?
I've been
We can,
SoCal so far.
Previously was SoCal, but
so I usually use the online thing, the app. So, you get all the scores anyway. So you just note them all down.
How do you talk to patients? Those who are, ELTS 12% high risk. Look at it, because there's a dying for leukemia related, death is very high, 12%. So this is one thing, if you put down on a case paper, how do you discuss with the patients? You put it down on your case paper, right?
Mm-hmm. Yes,
yeah. I think, sir, this is more relevant now that we have approval as well as access to second and third generation TKI upfront. So although only the prospective randomized trial will tell us that high SoCal and high UTOS score, ELTS score, treated with imatinib versus a newer TKI gives rise to a better outcome. That is for the time to tell us. But as of now, I think
ELTS data is a combined of all first generation and second generation.
Second generation. Yes.
So they are all there.
It is a combined data. It is not a comparative study. And where I think in the current some echo. I think. Am I audible?
Yes.
Yes.
Okay, yeah.
So probably this is a scientific knowledge only. I think this is a basic acumen. If we put that these patients are having high risk ELTS score, and we can anticipate that they are going to do poorly. So this is not a very strong proponent of starting second line TKI, but these are the cohort where you can think and discuss with the patient that, look, you are having a high risk disease to begin with, and probably starting you on these agents can be beneficial, more beneficial. So that is where probably we can use them.
Young patients, do you prepare them from transplant at this point of time with a high risk?
No, sir. Only first.
None of you talk about.
No, not at baseline, sir. Only if on monitoring, if you feel they are losing response, then.
Only patient with 315I who are not having access to ponatinib. Most of the people in India do not have that access. So that is one case scenario where we start transplant workup since beginning. Otherwise, not.
Asha, you also do the same?
Yes, sir. I mean, basically, if the patient is young or other things, usually I counsel them. Yeah, there is a high chance that you might require. So just to find out the donor, maybe in the later half when the patient is like during monitoring, usually I just keep HLA typing and just keep it aside, so that if really it is required, then you are aware that whether patient is having any donor or not.
Right. All right. Thank you. That makes it clear.
Sir, Amish.
Yeah, Amish. Yes, Amish.
Previous table, sir, one of the things when I read ELN 2020, the ELTS picks up more low risk compared to SoCal. In fact, recently I had one patient where on SoCal was intermediate and it is difficult for me to explain. And at the end, sir, 10-year overall survival in a 55 to 56-year-old patient looked similar. And ELTS had, as you write, second generation. So in fact, when I explained this table to patient asked me, sir, agar 10 saal tak same hi jeene ka hai, what is the point of going for expensive therapy? So this was the problem. When you asked that, what do you discuss with patient? I was just sharing my experience with you, sir.
Absolutely right. But we must not forget that these are European or Western country data. So ELTS, if we look at Indian cohort, we might get different kind of distribution as we get from the SoCal score. because we have more patients in the high risk, right? In so-called score, the data presented.
But sir, in this table,
PLT is adjust for the age, sir. That's the reason why the more number of patients are in the lower risk category than the so-called.
That's right. Not only age, if you look at the whole thing here, it is a very complex formula, I suppose.
Yes.
True.
So that's people those who have developed it, why all these decimal figures are there, how they have calculated, not our area, but I was looking at it, that calculation is so different. Anyway, we move on. So coming to it is again, when you look at BCR-able, some of us, like Gaurav and others will have in-house, but many people practicing would not have this in-house molecular studies. That's first session, Nikhil said that should have it, but it's not so easy. It's easier to talk when you work in an institute, academic institute, but in practice it's difficult to have this kind of data. So here you have the, when you outsource, so people will know those who are outsourcing or those who are working, even Gaurav also. Let's talk about conversion factor here. So conversion factor, does it worry you from the laboratory, your own laboratory or from the outside laboratory? It remains constant year after year. Ashay?
Yes, sir. Hello.
Conversion factor, suppose you have to send one of the outsourcing laboratory. Conversion factor is always 0.62 or something like that. With 2000, it was like that in 2020 also again. So does it bother you?
Not really, sir. Basically, the thing is that whichever laboratory, usually I keep one laboratory constant, like whichever laboratory we are using. So we just keep one laboratory constant because, that is a very practical problem which comes up, which may not be uniform across. So that is the only way out, sir.
Gaurav, you have something to say about it?
Yes, sir. So conversion factor is important, but when the international scale was developed, it was developed with the premise that the laboratory will, number one, get accredited with the international scale, and then they will keep on periodically updating that. So ideally, the standard sample should be tested periodically in those laboratories, the same one which is there in Adelaide, London, and I think Seattle. So that sample should be periodically tested to see whether the conversion factor is same or not. So that is ideal, but what happens, I don't know.
It changes. If you look at the data, look at very carefully the NICROSS data or data from Korea, you look at it, it's supposed to change actually. It can never be constant. It's just impossible because molecular methodology. So I have my concern. Amish, you have your concern. Uma, you have your concern about it.
I never really thought about it, sir. But yeah, like Ashay said, I usually stick to one lab, so it's easier for comparison. But in case this is such an issue, sir, how do you go about correcting it? I mean, we
need to talk to the laboratory.
Anything about it.
I think you should tell us about conversion factor more. I don't think any of us have so much of experience, sir.
No, I think we should talk to our laboratory. Have you sent your representative sample to the laboratory, which is the international laboratories or WHO? So it's very important that you have a dialogue with that. Why is it same all over? So it's very important, I think, about accreditation, whether they are doing samples properly, etc. So I think conversion factor is one thing that I would be looking. If the same for over 3 years in one single laboratory, I will ask them again and again. So that by asking, they will be very, they will become concerned about it. Next few months, you will see conversion factor is changing. Need to do that, I suppose. All right, thank you. We move on to the next one. So this is important for us, here and as a clinician. It's very important. So optimal is we know, failure we do understand. The warning factors are also most important for us. So what you do, Uma, if you have a more than 10%, or any of these. So additional chromosomal abnormalities, you may not get it because if you may not be doing all the time. But if you have more than 10% in a case, again, suppose someone is 30%, it's still more than 10%. You will take it as a warning of failure in your practice.
So I will see how big it is from 10%. So if it has come down, it's like 11 or 12, I will still continue, sir. But if from 30% it has just gone to 25 or something, here I would probably be a little worried and keep a little more vigilance on monitoring. and definitely have a discussion about a second generation TKI if the patient has been on a first generation TKI.
Right. Amish?
Hello.
Adherence, sir, I would ask within the first 3 months, I don't think I would change. Because many a times adherence also, intolerance also, and hematological toxicities are maximum in first 3 months. So after 6 months, I would follow the table very diligently. But first 3 months, as Dr. Uma said, I would be wary before calling it a failure, sir.
Okay. Ashay?
Yes, sir. I mean, almost I echo the thoughts with Dr. Amish. First 3 months are usually when they can have initial, bone marrow suppression, because it is mainly the Philadelphia positive hematopoiesis, and many of the times we had to modify the dosages. But yes, definitely it is more than 10%, and I will be quite vigilant. And usually I look at what was the baseline so-called score or ELTS score, basically, because that will also give me a rough idea how the patient is going to fare through.
So as they show in the last column, would you follow it every monthly after 3 months, or at the end of 6 months you would do it?
Sorry, sir, I did not.
Yeah, no, if there is more than 10%, do you do? No, sir. In my practice, I do after. But only thing is that, as Dr. Uma said, actually, see, here the guidelines is you do not do RQ-PCR at the baseline. It is just RT-PCR. But if like baseline RQ-PCR was done, it was like more than 60%, 56, 60%, 78%. And it is come to say 12%. So definitely it is a response. So usually in that cases, maybe after 3 months. But I think there's something which you have given, you baseline, you have a very low score, something like PCR, maybe, at least 15%, 20%. Then really it is a worrisome thing, because then in that case, maybe after 1 month, I repeat.
So I would repeat after 3 months usually if you are monitoring.
Okay. All right. Thank you. We move on later on. So,
Sir, Amish here. Sir,
yes,
sir, Amish.
Please.
Sir, you have the highest experience, sir. At each table, we would like to know your opinion also, even though you are the moderator, sir.
Yes,
but
sir.
It would really help us in our practice, sir.
So I get worried. I'll be very honestly, more than 10% looking at the patient, those who come with the high risk. So it's like a high risk patients. I will be definitely worried. Even in low risk patients with the more than 10%, I really get worried, because these are the people, probably the young people. If I see majority of them, they go into the accelerated phase of developing resistance quickly within next 2 to 3 years time. So personal experience, I see that I get worried about. So I need more than 1 log kill right in the beginning at 3 months time. So that's my aim always, whether I use a first generation imatinib or second generations. That's because of patients keep seeing. So it's a personal data, personal experience, but this is the last data. So you can European, again, they say recommendation. So you can individualize your cases. I think we need data all the time. So if I say only personally, that may not be, but I get worried. If there's a no 1 log kill, I get really worried, because that means
Dr. S.K. Basu also has written in the chat, I could read half. If this is the case at 3 months, do you increase the dose of imatinib if you are using first generation TKI?
Of course, there is a choice for that. Yes, we do that in patients with 800. Tolerance becomes an issue, but yes, if you have no option for the second generation drugs, patient doesn't want to buy it. So yes, definitely there's data from MD Anderson. They have shown that. There's a data from German studies also. There's data. There are other data also. I think Friends Group also, they did it. So I think one can do that. Right. Move on. This one, and if you do it at some point of when you get it, this is very specific abnormalities. We know 3-on-N2 isoleucine 315I mutation ponatinib, but others, have you have any experience with using this kind of mutations, 317 with various amino acids coming in, 299 or 253, 255, 359? Do you choose drugs? Yes.
Yes, sir. In B299L, we have seen, I've seen, sir, because nilotinib basically. Only thing I just wanted to ask, like in this table, you do IRMA mutation at what particular point of time? So means if you have the failure, maybe at 3 months only. If you are changing to other TKI, do every one of us do IRMA at that time?
Yes, I think so. If you are changing the TKI, then it's best to know the mutation so that you may choose the right one.
Yeah.
Okay.
Right. Right.
Because
yeah.
And have anyone any experience, because one of my patient she had initially V299L, and I started switched it on a nilotinib, and within 8 months she progressed, and that time she was having T315I. So actually so baseline IRMA never detected T315I, but in the subsequent it detected T315I.
I think we keep using it.
Yeah, what we read also is that we need to see what sequencing method they are doing. Sanger sequencing does not pick up especially 315I, and you have to insist on NGS. As Tapan sir said about the conversion factor, I think here Sanger sequencing should not be done. Many of the labs
NGS
are doing
based.
Sanger sequencing. It has to be NGS based, otherwise it misses the mutations.
So Ashay, I
Yes,
have a request to all of you, those who are listening also. I have not seen this word or acronym IRMA in textbooks or in the articles.
Okay, so
these are laboratory people. This is imatinib resistance. I think we are far beyond it. I think called ABL KD domain mutation. So IRMA, I have not used it in my life because I feel that that's not correct, because sometimes you start nilotinib, you start Dasatinib as the first line, you can't call it IRMA. So I suppose ABL KD mutation is a right term to use it. Well, my young people all the hospital, they do it, they get my, Amish knows it, what I do. Okay.
Yes, sir.
Thank you. So we move on, that this is the most difficult area. So we are talking about transplant right in the beginning or not, because most people will not have access to ponatinib. Do you counsel them for transplant, those who fail?
Yes, sir.
Yeah.
We don't have much option. Transplant is their best bet.
You have been doing it, right? Gaurav,
Yes, sir. We are transplanting. Even, I think I remember, we have done one haplo also for one patient with T315I.
Right.
Yeah.
So ponatinib, anybody has access to ponatinib, using ponatinib?
No, sir.
Not yet.
At our center, we have a little experience with ponatinib, and few patients could get it through some support program.
Right.
However, they are just on single digit, so not a great experience, not a large experience, but yes, we have used it at our center.
Same here too. Some of our patients have gone to Singapore. They have been on ponatinib for a long time, and they have come back now. So it's a challenge now how to get ponatinib for them, once the trial is over. So, transplant, yes, transplant results are improving, but depending on that, when you pick up these patients, earlier you do would be better. If you wait till blast crisis, it's extremely difficult to treat them. Whatever it is, a myeloid blast crisis or lymphoid blast crisis, long-term outcome is not very good. So as soon as younger people, they lose a response to any TKI, intolerance is another thing, because all the data we get to see good response to the second generation after moving from first generation. Intolerant people, they are doing much better because they're still responding. But real resistant cases, majority of them wouldn't do very well with the change of the TKIs. That's a big challenge. If you look 5-year, 6-year data with the second generation, either nilotinib or dasatinib.
Sir, if ponatinib is not available and you do KD mutations study and you find translocation 315I, of course, normally we counsel for LOSCT and transfer to the patient where transplant is done. But in the meantime, do you change to any TKI which is not used, or what is the practical approach in these patients when ponatinib is not available, sir?
Right question. The recommendation is that the papers, if you would see that you got to stop the TKIs. Continuing TKI might create more problem. That's the data available in a small number of people. So if someone is imatinib resistant and there is a still UHC patient has 315I mutations, and then probably you should take it off, get back to other older drugs, even hydroxyurea.
Sir, I think, may I respond to Dr. Amish? Yes. I think in that setting, we have access to interferon. We have RAC. So if the patient is having large counts, you can just start them. And those were the therapies when, there was no TKI in the world. So
Gaurav, my question was specific. Is it interferon alone? Is it interferon plus RRC? Till the time a person is preparing for LOSCT, what do we, as an Indian level, what do we do? Do we combine RRC with interferon? Do we give only interferon? I know all these drugs are available.
I will share I agree with you. So I got the question in a way that patient does not have access to transplant. So in that setting, it comes. Whatever patient, we have transplanted patients and we transplanted the moment we detected 315I, we did matching. And even if there was a haplo, so nothing is needed because you are going to use, abuse-I or maybe other regimens. So it's going to kill everything. So that maybe I understood the question in a different way.
Other than the first author in this ELN, Andreas Hockhaus, warned that interferon is a disaster in the sense that not from the efficacy point of view, no one is going to manufacture it. Whatever you have now will dry up in 1 or 2 years' time. So I think that a good drug we are losing now because no one wants to make it because there's no use in any other settings outside oncology as well, in hepatitis, adjuvant, whatever. So melanomas, etc.
Absolutely, sir. The biggest market for interferon used to be hepatitis C. And now we have so many good small molecules for that. There's some role in cutaneous T-cell lymphoma where people are using, or maybe some immunomodulation here and there. Otherwise, this drug is going out.
Just one question, Dr. Gaurav. Hello.
Yes.
Dr. Gaurav, hello. Can I just so usually see like post transplant we do like chimerism monitoring as well as MRDs also, right? So in case of T315I, if you have transplanted, do you do MRDs also in those cases, or what maintenance strategy can we use if at all?
So because in those patients we do not give any maintenance. The main premise of doing transplant in these patients was because TKIs were not working. So those patients, we just monitor them for the way we monitor any other transplant with chimerism. If they are not losing chimerism, then we continue and monitor those patients and most of them would be cured if there is no other clonal evolution. So MRD is not done. It's not unless you are thinking of patient having dual clone and you are doing MRD for one. No. So in practice, I think because we don't have any avenue to give to the patient as maintenance therapy, not check for it.
So our time is up, and then we had a beautiful discussion. You have really contributed. I hope people, those who are listening, had some benefit from our discussions. We tried to be extempo, not willing, and keeping something for future also to TFR, etc. There'll be talk later in this meeting. So thank you so much, all of you.
Thank you, sir.
Thank you, sir. Thank you for it.
Thank you very much, sir. Thank you, organizers.
Thank you.
Thank you so much, sir. We'll move on to our debate. Our first debate is donor for BMT in CML, AP or BC. Our first debater is Dr. Prashant Mehta, medical oncologist from New Delhi. Over to you, sir. Prashant, sir, can you hear me? You'll have to unmute your mic. Hello. Prashant, sir, can you hear me?
Prashant, we have to unmute your mic. We can't hear you.
Can you hear me?
Yes, sir, we can hear you now.
Okay, fine. So I said there are many reasons why I would choose haplo for my advanced CML patients. So it is available for almost all patients. And the donor is chosen from the family, and there's no undue delay due to logistics, and the donor-derived therapies are also easily accessible. But there's some issues probably. The experiences are evolving, and infections and delayed immune reconstitution is a problem. Some patients may have a graft failure, maybe about 5 to 10%, but there are certain issues with mud as well. There is a lag period, logistic delay, and the registries don't have as many donors for Indian patients as for others. Cost is again an issue, and there's limited access to donor-derived cellular therapies after the transplant. So this is a survey I put up on Twitter, and I found that 60% of transplanters, they favor or at least feel that haplo is as good as mud and in CML, advanced CML who has reached a CP2. So whether replete or deplete in the Indian setting, I would say replete PTCY strategy. What is the data? So this is some data in the myeloid malignancies. You can see very well that the PTCY strategy, the survival is as good, and the GVHD rates are lower actually than the MUD, and the non-PTCY strategies. So this is the outcomes, and you can see the Kaplan-Meier curves. They are pretty opposing. The survival is not different, but you can see in the bottom right-hand corner that the adjusted curves in the chronic GVHD. The chronic GVHD is more for the MUD donors. Another study with the TCD, the T-cell depleted haplo versus MUD in more than 60 years, the GVHD rates were not different, but extensive chronic GVHD was much more with the unrelated donor transplant versus haplos. And this is data from Peking University in CML BC. I could not find much data for CML BC. It's pooled in with the myeloid malignancies mostly. The overall survival in RFS is again the similar in the Peking University data. This is the GIAC strategy, not the PTCY. And then again, we have some more data from China coming from the GIAC strategies. Is 90 patients. The RFS OS was not different, and the GVHD rates here was more actually in the GIAC strategy versus the MUD donors. But the GIAC is a different strategy. It's not PTCY per se. This is data from a Swedish group, 10,000 patients, myeloid malignancies, more than 800 haplos. There was no difference in relapse rates, and the leukemia-free survival was although more in the matching sibling. But this is again matching sibling data compared to the haplo. So the non-relapse mortality, which we worry about in the haplos, was not too different. So some other retrospective studies from Siuri et al., MUD versus PTCY haplo, the GVHD was half with PTCY, and there was no difference in survival. We don't have too much head-to-head data. Most of this data is retrospective, and it's very difficult to have head-to-head data in a disease like CML, BC, and CML is not the very common indication for transplant anymore in the world. So there's again some data from Rayola et al., MSD versus MUD versus COD and haplo PTCY. Here also haplo did as well or a little better than MUD. The MSDs did better, and the COD was better in respect to GVHD, and GVHD was lower with the COD blood transplants. This is again data of 10 odd transplants in CML BC. Safety and efficacy, it was found to be safe, and the outcomes were pretty okay. And this is our center data, the feasibility using cyclosporine haplotransplants in hematological malignancies. We had 6 CML BC in this data set, and one out of this was a MUD. He died of relapse at 1.5 years, but also had a lot of GVHD. There's one matching sibling donor, he is alive. 4 haplos we did for CML BC, 2 out of those 4 are alive, but 1 out of these 4, he died actually recently of COVID-19. So you could say that 3 out of 4 were actually doing pretty okay, and these were long-term survivors, more than 3 years, all of these. And this is the overall survival with the PTCY strategy from our data set, and you can see the overall survival here 68%. The relapse free was 65.4%. The median follow-up was 8 months, and some of these patients were actually long-term survivors. And we also found that in the Indian setting, cyclosporine is a feasible option instead of tacrolimus. So what determines which of these transplant strategies are better actually? So we look at GVHD infections, logistics, ease, learning curve, because this is something new which has come up, the PTCY, although it has picked up a lot, and there's a tsunami of haplos going on in India right now. Pediatric versus adult, there is a different. Pediatric PTCY does not work as well. The non-malignant, it does not work as well. But yes, the malignancies, myeloid particularly, even with the RIC strategies, does well. In the lymphoid malignancies, the PTCY haplos, the relapse rates are little higher because the intensity of the conditioning is not as great as it should be or can be with MUDs. So haplo PTCY in the developing world, this is some combined data from Europe and also some data from Israel and China. And the world feels now that PTCY is here to stay, and the learning curve is also pretty steep. It can be done in resource constrained settings. The cost is less of a constraint than we have the cost constraints for MUD. MUD is again a lot of logistic delay. Once you have achieved a remission in CML blast crisis and achieved a CP2, you don't want to delay your transplant. You want to do it as soon as possible. But this haplo PTCY is possible in newer centers as well, and the learning curve is pretty steep. So overall, I would say transplant as soon as you have achieved a CP2 in advanced phase CML. Don't wait. Also, if you have somebody who has developed resistance to TKIs and something like a T315I, it is better and better to transplant as soon as possible rather than waiting for a long time. The outcomes are not good when CML patients are transplanted in advanced phase. They have to be, you have to control the disease first, try and achieve as deep of a remission as possible. So whether you do it with a MUD or a haplo, you have to achieve a remission. That's how you can achieve long-term outcomes. Also, the post-transplant maintenance strategies, the TKIs, sometimes drugs like AZA, drugs like maintenance drugs, they are also very important. DLI has an important role. You have to use an early DLI. You have to monitor the chimerisms very strongly, and the lineage-specific chimerism do play a role with that. The T-cell chimerisms, the myeloid chimerisms, all has to be monitored. Otherwise, you're going to lose your patients to relapses most often than not. So haplo is a viable alternative for myeloid malignancies, including advanced phase CML and CP2, but head-to-head trials are missing. Still, the MUD is going to become more of a problem in the COVID-19 era. With the pandemic going on, there are going to be more logistic delays, more concerns. So haplo, you have it there near your institute, in the family. It is the strategy to go for, and you have to optimize it. Thank you.
Thank you so much, sir. We'll move on. Our next debater is Dr. Sanket Shah, hemato-oncologist from Ahmedabad. Over to you, sir. Sanket, sir, you'll have to unmute your mic. Sanket, sir, you'll have to unmute your mic. Sir, if you can hear me, you'll have... yes. Hi, sir, can you hear me?
Yes, yes.
Yeah, perfect, sir. Please go ahead.
Yeah. So Prashant sir has nicely mentioned all the points. I am also saying that there is ongoing tsunami of haploidentical transplant in the India. This article was actually published in 2015. But currently, if you see in any transplant debate, you will see the haplo data and how the haplo outcome are increasing. But whenever we are talking about the haplo and the advantages of the haplo, we have to take all that advantages with the pinch of salt. We cannot make all the advantages as very good advantages. So if we see easy availability of donor, I agree with that, if there is not a pandemic, the donor registry is not that good in the India. But here in this, for the sake of debate, it is the question of choice when you actually have both the donors. You have a MUD donor as well as haplo donor. And then the question of choosing the one. If you don't have MUD, obviously the haplo is a choice. But if you have the MUD, you can go with that. Why? So in haplo, we say that donor is readily available. And CML-BC, exactly sir has said that you want to do transplant once you achieve the CP stage. So it is not like a aplastic anemia condition where you have to do transplant as early as possible, but you have to give some chemotherapy, you have to give TKIs, you have to take 3 to 4 to 6 to 8 weeks to achieve the remission. And thereafter still you can give some trial of TKI or consolidation chemotherapy till you can get the MUD cells. The other is you also have the donor for DLI. I agree that the DLI is good for the CML, but we are not using prophylactic DLI as a routine practice in usually. DLI has actually the minimal effect once you have the overt relapse. It is definitely useful when there is a molecular relapse. But when you are using the post-transplant TKIs, the relapses of the post-transplants have also reduced. Hence, just for the sake that you have the donor available for DLI, you cannot take the donor for the haplo instead of MUD. The next argument is usually that the patient having the same genetic makeup in the family, so the rejection chances might be rare. But we all know that the HLA is particularly the most important factor in the immune regulation or rejection. In MUD, the HLA matching is 100%, while in the haplo, it is around 50 to 70%. So if you select the haplo, we are actually relying on some unknown, untested genetic similarity over the known, visible, and the most important HLA similarities. And I would say the science is more about the observation rather than our belief of making and matching. The last thing sir has told, the cost. Actually, in the ideal scientific setting, we should not discuss anything about the cost. But in the real world, we have to discuss this factor most importantly. So agreed, the cost of the MUD is much higher, a bit higher. But when you see the engraftment rate in the haplo, it will usually take 1 or 10 days more compared to the MUD transplant, 7 to 10 days more, usually 7 days. And if you see that 7 days of neutropenia, stay in hospital, antibiotic, nutritional support, it all have their own costs. But in India, we all have the high prevalence of the MDRO. So 1 week of prolonged neutropenia significantly increases the risk of life. And we cannot calculate that cost of life with the money for sure. The next is efficacy. This is another important perspective. The mud transplant is there for more than 4 decades now, while the most of the data of Heplo are usually in the last 1 decade or max 1.5 decade. Moreover, with the advance of the TKI after 2000, CML BC incidence have significantly decreased. So as sir has rightly mentioned, there are no head-to-head comparative trials or any prospective studies of the mud versus Heplo in the CML BC or even AP. But some data are available, like this was in the 2018 analysis, 25 studies, more than 11,000 patients. And what they have said is Heplo transplant should be considered. It is safe and effective, but when the match donor is unavailable, and it is less suitable for the reconditioning. The another article, which is published by the Tfr Studies group from the MD Anderson, who specifically looked on the donor type for the CML transplant in 2018 or 2019, they have published a retrospective study of 14 years. And what they have said that the Heplo donor offers at least as good PFS and GRFS as HLA matched transplant. So it is not superior, it is just matching. So more importantly, it is the non-inferiority studies. Even in the up-to-date 2019 or recent studies, which editor of Nelson Chow also saying that Heplo or cord blood should be used only when you do not have a match-related or match-unrelated donor. So clearly, though the outcomes of haploidentical transplant is improving drastically in the past few years, I would still strongly recommend match-unrelated donor over the haplo transplant because of our old experience and more of the importance in the Indian context, except for bearing cost as well as some logistic delays. However, actually, the question is haploidentical transplant is better than is actually the wrong question, which is nicely published in this article. Instead, our future studies should aim to identify the base donor type at a much more granular level or personalization of the patient. According to the patient, we should decide whether this patient requires a haplo or the donor, rather than making a generalized statement across the group that CML would be helpful from these or like that. Thank you.
Thank you so much, sir. We'll move on to our next debate. Our first debater is Dr. Manju Sengar, hemato-oncologist from Mumbai. Over to you, ma'am.
Thank you, sir. Thank you, everyone, for giving this great opportunity. I have 5 minutes in which I'm going to present the evidence that ABL kinase domain mutations are best diagnosed by next generation sequencing. So who need this testing? All patients who have CML chronic phase or advanced phase, if they show failure or warning, irrespective of whatever the line of therapy, they require ABL kinase domain mutations. And if you have, advanced phase disease, even at diagnosis, you would need ABL kinase domain mutations. If you look at the conventional methodology, 1/3 of patients who have chronic phase and 2/3 who have advanced phase disease will be picked up by these technologies that they have kinase domain mutations. And this current methodology is Sanger sequencing. Sensitivity of this methodology is around 20 to 25%. That means if you have BCR ABL transcripts with less than 20-25 in number who have mutation, you will not be able to pick up by Sanger sequencing. And therefore, it's not good for low-level mutation. Another important thing which this technology cannot pick up is polyclonal versus compound mutation, which has implication in terms of progression of disease to the advanced phases like accelerated phase and blast crisis. So what do we have anything better than this? And that's where the next generation sequencing comes in. And here what we are talking about NGS platform is the panel of genes or the genetic regions of interest, which are sequenced hundreds or thousands of times in single run, and therefore it achieves high sensitivity. The sensitivity can be 1%, as low as 1%. And the mutations which are picked up at the frequency of 3 to 20% of transcripts are called low-level mutation, and more than 20% are called high-level mutation. What's the evidence to say whether next generation sequencing is better than the Sanger sequencing or the other conventional methodology? There's retrospective studies which have said that you can pick up kinase domain mutations 2 to 11 months prior to a documented failure or prior to be detected by Sanger sequencing. Not only that, there are backtracking studies in patients who progress while on TKIs to advanced phases, and the NGS can pick up the occurrence of deleterious mutations like T315I almost 3 months before the Sanger sequencing, or when you start picking up the failure of disease in terms of clinical presentation. Does it have any clinical implication to pick up these mutations earlier or detect at the low level? And there is data to say that patients who have complete cytogenetic response, but if they have these low-level mutations, they are at the risk of failing complete cytogenetic response. There is population-level data to say that those who have kinase domination, they are showing response, and this is done as early as 3 months into therapy. Their outcomes are worst. So yes, low-level mutations seem to be important, but the criticism may come up that these are all retrospective studies. So we do have a prospective study which was published this year earlier, where almost 236 patients who were having non-optimal response, meaning either they were failure or warning as per the ELN criteria. Their next-generation sequencing and Sanger sequencing was done across 4 reference labs. And the study was done to look at both feasibility, because that's one of the major concerns probably my opponent is going to have, that it's not feasible to do next-generation sequencing. So yes, there is enough data to document from this study that there is feasibility. What it did pick up, that if you look at the left-hand side, only 25% of these non-optimal responders had mutations when they were evaluated through Sanger sequencing, versus you can see almost close to half of them having a mutation. Not only that, these patients who had high-level mutations, half of them had low-level mutation along with the high-level mutation when the NGS was done. And almost half of the patients had low-level mutation. What's the relevance of it? The relevance of picking these low-level mutation is that almost half the patient who had warning, who had failure, did not have any mutation by Sanger sequencing, but you could pick up a mutation by NGS, and therefore you can intervene. Though in this study, intervention was not must, it was left to the physician choice, but you can intervene early and you can avoid the progression of disease to the advanced phase of the CML. Patients who had warning sign, even in that, almost 1/3 of patients were having low-level mutation. And by low-level, I mean anywhere between 7 to 20% of the BCR ABL transcripts. And these individuals also had actionable mutations. And therefore, you can act earlier and you can prevent the progression. And this study very elegantly looked at the progression of these individuals who had otherwise warning category of response, but the disease progressed because there was suboptimal inhibition of this BCR ABL clone due to an inappropriate TKI being given. And so therefore, there is enough prospective data now to suggest that the NGS can pick up much more ABL kinase domain mutations, which are clinically relevant and can improve the progression-free survival and reduce the risk of transformation of disease to the accelerated phase or the blast crisis. Worries which will come up closely is that the cost and the availability, the study didn't look at it. And if you look at, depending on what NGS machine you are using, the cost was lesser than the Sanger sequencing cost. The timing was a close match, 15 hours versus 13 hours. And they clearly documented in the phase 1 of these studies that the referral center who have experience in NGS, this is very doable methodology. So with that, I would conclude that low-level mutations are relevant and which can be only picked up by the NGS. And this will allow early introduction of an appropriate TKI. And NGS is doable, and it seems cost-effective if you look at in the long run. And to end, the debate is not between me and Hari, it's Sanger versus Sanger. So with that, I will end and I'll hand over to Hari.
Thank you so much, ma'am. Our next debater is Dr. Hari Menon, hemato-oncologist from Bangalore. Over to you, sir.
Thank you. Thank you. Let me just share the screen. So, as it's always tough to debate on something that is already proven in terms of the superiority of a methodology in picking up deeper responses, deeper abnormalities in the form of kinase domain mutations. That is the topic of debate today. So I would just go ahead and say that first, I would not debate on this in terms of the sensitivity to pick up kinase domain mutations. Definitely next generation sequencing is a superior methodology because the technique itself is a lot more refined, and it is certainly more sensitive method to identify mutations, including kinase domain mutations. But the question over here is whether it is required for routine management of CML just because you have a very sensitive assay. And is there a recommendation for its use for now, for the future? For now, I would say not ready for real time. For the future, perhaps when things become a lot more available. And should it replace Sanger sequencing? Well, let us see. Manju has already discussed several studies which has clearly shown its the ability for the NGS to pick up far more subtle mutations that are present, what we call as ultra deep sequencing. And so I would say that whether it is ready to replace Sanger sequencing, whether we can still stay with Sanger sequencing for our day-to-day management of patients, well, that is something which I would say, as of today, that's perhaps okay to still stick with Sanger sequencing. But there is, so what do we do about using NGS? Should we use it in real time at the time of diagnosis of CML? Actually, there is really no recommendation for any ways for mutation testing at this phase. And if we do test by next generation sequencing, which could be perhaps a research protocol, we may pick up some mutations, possibly, as Manju alluded to. We do see almost about two months to 11 months before picking up a mutation by an NGS as against by a Sanger sequencing. So there is a lead time where we can pick up these mutations much earlier by an NGS. But they are not likely to be induced by TKI in the early phase or before starting a TKI. And identifying these mutations by NGS have not been used to actually formulate recommendations for its utilization or for the matter to change our line of therapy in any way. Perhaps they may be used for those patients, as Manju did allude to, when there are warning signs, when there is not an optimum response. Earlier, we used to use the suboptimal response concept in CML. And when you have a warning sign, which is what is more used today, maybe yes, in those situations, if we do pick up a mutation, we can attribute the lack of response to that mutation and perhaps take an evasive action. I would agree in that situation. If you look at the use of NGS sequencing before an allogenic stem cell transplant, may be useful because when we it may be useful should a TKI treatment needs to be started after the transplant. So if in a non-responder, you may pick up mutations that may lead to failure on the long run, even to a transplant. So it may be useful in those situations to distinguish between compound and polyclonal mutations. Certainly, the NGS is a superior tool over there. But longitudinal monitoring, well, you really cannot anticipate relapse in the post-transplant setting on a longitudinal monitoring because it is also understood that low levels of BCR-ABL may persist even 10 years post-transplant, and there is no real significance in identifying the same. And if you look at the ELN recommendation, still suggests that Sanger sequencing may suffice in these situations. So is NGS required in advanced CML? Well, the frequency is much higher in these patients. Sanger sequencing would probably be adequate and pick up these. Yes, NGS would score over here, but do we need to replace it with a Sanger sequencing? It remains a question. But NGS can pick up compound mutations, no doubt, and may be indicated for instituting sometimes personalized therapy in these patients. Now, if you look at, is there any role for monitoring after a TKI discontinuation? The answer is no. And if you look at identifying low-level mutation, does it matter if the patient is responding? It did not lead to any clonal selection on the long run. In some of the studies that have been shown, you did identify those mutations, probably with by ultra-deep sequencing, but they did not really impact, and there was really no, many a time there was really no clonal selection over there. So there is no recommendation to change your line of therapy just because you had a sensitive assay to actually detect these mutations. So currently, there is really no hampering of the management of CML because we did not do an NGS testing in these patients. And it does not represent inappropriate management of the CML in the present day just because you didn't resort to an NGS mutation. But I would accept as a person who likes to look at newer things and a researcher mentality, I would still think that probably there is a role for it when it can be applicable on a larger scale. We do understand that it is an expensive test. You need a lot of expertise, and there's a lot of cost involved in setting up a lab with an NGS equipment. The overheads are there. So maybe in a country like India, maybe it might be still a long way to look at implementing such a methodology. I would say to end it, it is not for all, but I would certainly say that it's appropriate for the research setting. Thank you.
Thank you so much, sir. We'll now move to the third sponsored session. This session is sponsored by Intas, and our speaker is Dr. Sameer Melankari, hematologist from Pune. Over to you, sir.
Hi. Please tell me if I'm not appropriately audible.
Sir, you're audible. You're perfectly audible, sir.
Yeah. Okay. So the topic of my talk is frontline usage of Dasatinib in Ph+ive CML. So a few introductory remarks. In the absence of treatment, we know CML progresses from chronic phase to accelerate phase and then blast crisis. CML treatment revolution started with imatinib, and now we've gone on to second and third generation TKIs. And survival in chronic phase CML is now near to age-matched controls. And there are 4 agents which are approved for frontline treatment of chronic phase CML. So we have a choice of therapy. We've been spoiled for choice, and therefore choosing the appropriate therapy can be a little bit of a challenge. So in general, if you have, you could decide to choose your TKI based on the side effect profile of the drug, the comorbidities, patient preference, cost, and the CML risk score. Based on the CML risk score, you could decide, if it's a low or intermediate risk CML, you may prefer to start with imatinib or one of the second generation TKIs. However, if it's a high risk CML, you may want to start off with the second generation TKI rather than imatinib. However, we know that imatinib can also be equally good in certain high risk cases, and therefore it's a matter of choice. No individual second generation TKI has been proved to be superior in this setting. And so preference for a second generation TKI is informed by observations that progression to accelerate phase and blast crisis, that is a concern in high risk CML patients, is much lesser with the second generation TKIs than imatinib. So why second generation TKIs? Because the responses are deeper and faster. There is also a lower rate of transformation and lesser kinase domain mutations. However, as we know, the OS, PFS, and EFS are not different. The best second generation TKI, there's no direct comparison between dasatinib, nilotinib, and bosutinib, and therefore you cannot say which is the best. And if you put studies side by side, it's not a correct way of interpreting at all. So the data is overall comparable between all of them. As per the NCCN guidelines, is just what I sort of mentioned. If it's a low risk score versus an intermediate to high risk score, a low risk score, they say you could prefer a TKI, but also you could go on to a first generation TKI, but you could also go on to a second generation. And if it's an intermediate or high risk score, you would prefer to go on to a second generation TKI. and other recommendations could also be imatinib. So here again, because of the quicker molecular responses, both the MMR as well as the MR 4.5, it is preferred that you could start with a TKI to facilitate subsequent discontinuation of TKI. So as we know, treatment-free remissions should be the norm and the goal for all your patients. And therefore, as we know, you could get a deeper and a faster response with TKI, and therefore you might be able to facilitate the stopping of the drug. And this is most important in this particular set of patients, younger ones, and especially women, because we know that we need to, before a woman becomes pregnant, we need to stop the TKI, and then she will be off the TKI for 9 months, and you don't want the patient to relapse in this phase, and therefore you would want to get them quickly into a good remission. Comparing the toxicity of the TKIs, as you can see, the imatinib, dasatinib, and bosutinib, ponatinib, generally they have similar side effect profiles in terms of bone marrow suppression, fluid retention, GI side effects, and CCF related to fluid retention. Nilotinib has an important side effect of atherosclerosis related events, electrolyte imbalances, and QT prolongation is a black box warning for this drug. For ponatinib, the black box warning is arterial thrombosis and hepatic toxicity. So, individualizing therapy in CML. So, if you look at the comorbidities, and then you could decide which TKI you want to choose. If you've got a patient who is particularly at risk of pleural effusion, and he's got a lung disorder, uncontrolled hypertension, you may want to avoid dasatinib, because this is the commonest side effect of dasatinib. Pulmonary arterial hypertension, you want to avoid dasatinib. If there are risk of hemorrhagic complications, patients on anticoagulants, these are increased with the dasatinib and imatinib. Uncontrolled diabetes, just use nilotinib with caution. Any patient with a vascular disease, avoid nilotinib or use it with caution. Hepatic impairment, reduce the dose of bosutinib. And renal impairment, you would need to reduce the dose of imatinib by at least 50%. That's the toxicity spectrum that I just was mentioning. All right, now I'm going to discuss two important studies. Just going to review these studies. The first is the Dasatinib, which we know was a comparison between dasatinib and imatinib for first-line therapy of chronic phase CML. The objective was to look at the 5-year results of these patients. Patients were randomized between dasatinib 100 milligram once daily versus imatinib 400, and the primary endpoint was confirmed CCR at 12 months. So it was quite clear that dasatinib induced a better 5-year MMR versus MR 4.5 as compared to imatinib. This was statistically significant. However, the PFS and the OS were, as expected, the same. The complete cytogenetic response for dasatinib and imatinib were statistically significant, more for dasatinib. Number of deaths were the same in each arm. Transformations to accelerate phase and blast crisis on after on the study or discontinuation were lesser for dasatinib as compared to imatinib, and these were also significant. Drug-related AEs were manageable, leading to discontinuation in 16% of patients on dasatinib versus 7% patients on imatinib. The other, you can say, a byproduct of this study was this is not the intended, what shall I say, endpoint in this study, but this is a byproduct, the responses at 3 months. Slightly controversial according to many, but these are the results. At 3 months, less than 10% versus more than 10% RQ-PCR values. As you can see, there's significantly more with dasatinib as compared to imatinib. The cytogenetic responses, the MMR and the MR 4.5 were all more in favor of dasatinib. And it was noted that the 5-year OS, the PFS, and the transformation-free survival If you were less than 10% versus more than 10% at 3 months, they were statistically significant. So if you were less than 3%, less than 10% at 3 months, you had a better chance of an overall survival, a PFS, and a transformation-free survival. And this is sort of followed by many around the world in the guidelines as well. That if you haven't responded well at 3 months, you could decide to change from first generation to second generation TKI. In terms of safety, I would just say that so this is, I mean, on the right side, is favors imatinib. So dasatinib has a problem of abdominal pain and headache in addition to the pleural effusions that we spoke about. Most of the other side effects are kind of favor dasatinib, and therefore many patients who have side effects on imatinib tend to go on to dasatinib in our routine practice. The authors' conclusions from the Dasatinib study were that as compared to imatinib, patients with dasatinib had faster times to response, higher cumulative rates of molecular response, fewer transformations to AP or BC. The PFS and the OS were the same. Achievement of BCR-ABL at less than 10% at 3 months is associated with a significantly higher PFS and OS at 5 years. And safety profile kind of remains consistent throughout. Pleural effusions occurred in about 20% patients, but only about 6% of these had to discontinue treatment. Arterial ischemic events were uncommon with the dasatinib, only 5% patients. Right, and this was the sort of investigator commentary on the final results of the Dasatinib. It continues to show superiority of dasatinib over imatinib with most of the endpoints achieved, seen, and the CCYR at 5 years is more in favor of dasatinib. And importantly, the differences in MMR also maintained at 5 years in favor of dasatinib. So the question is why there is no difference in the survivals, and that is because those who are on imatinib and who don't achieve a good response, they can always be salvaged. There are salvage therapies. They can move on to second generation TKI or a bone marrow transplant, and ultimately the PFS and OS are not very different. Right. Now, just a word on how to manage pleural effusions, which is a sort of important and irritating side effect of dasatinib. Fluid retention is common. So anybody on dasatinib, you closely sort of monitor for these symptoms of respiratory pulmonary symptoms, dry cough, dyspnea, etc. You do the appropriate workup. You would do chest X-ray, PFTs, and echo. And you would conclude whether the pleural effusion is small, medium, or large. If it is small, you continue to sort of monitor every 3 months for appearance of symptoms, repeat a chest X-ray, 3 monthly for the first year, then 6 monthly for the second year, and then decide whether you want to reduce the dose. Remember, we are talking about 100 milligram once daily as per the Dasatinib trial. If the patient is symptomatic, you consider reducing the dose depending upon the therapeutic response of the underlying CML, repeat the chest X-rays. If the size of the pleural effusion increases, then you may want to refer it to a pulmonologist. Or if the patient is presented with a medium pleural effusion, then you would interrupt treatment until this problem is resolved. Many doctors prefer to use a touch of steroids to accelerate recovery. You may resume then with a reduced dose depending upon the therapeutic response, right? And if it is a large pleural effusion, in conjunction with a pulmonologist, you would want to perform a diagnostic and therapeutic thoracocentesis. And if it kind of recurs rapidly every 2 to 4 weeks, then you may want to consider drug discontinuation if more than 2 thoracocentesis are required. If that's not the case, then you may want to interrupt the dose for a while and then re-challenge with a reduced dose. Yeah, so I kind of said most of this, and one must remember that patients who are sort of effectively managed pleural effusions have shown to achieve good clinical responses. So in fact, those who achieve a pleural effusion, who develop pleural effusion, are said to actually have responded better in terms of the response to CML. That's an observation. And they may continue to gain long-term benefits with dasatinib treatments. Hence, you must sort of not just immediately decide to discontinue unless it's an unmanageable pleural effusion. This is just an analysis of the Dasatinib trial in the East Asian population, whether they sort of differed in terms of response as compared to the Caucasians. And there was 60 on the dasatinib arm and 48 on the imatinib arm, and it was noted that all the responses in terms of molecular responses, cytogenetic responses, were kind of more in favor of dasatinib as to imatinib. It was just noted that related to the non-East Asian patients, incidence of rash and fluid-related events and the cytopenias were probably higher in the East Asians regardless of the treatment. Yeah, it's just a demonstration of the molecular and cytogenetic responses. Safety, I just discussed this, so we won't. So to conclude, the overall findings of the analysis of the Dasasion 24-month data provide further support of the use of dasatinib 100 milligrams once daily as first-line treatment for patients with newly diagnosed CP, both East Asian and non-East Asian countries. Now, if you want to ask me what is my sort of practice-changing study, at least personally, I would say it is this one. This has changed my practice. And this is from MD Anderson. It was published in February or March of this year in Cancer. Long-term follow-up of lower dose dasatinib 50 milligram once daily as frontline therapy for chronic phase CML. So it was noted, we've also seen this, that when you reduce the dose of dasatinib, actually the patient never loses his response, even in Ph+ive ALLs. And dasatinib 50 is sort of been approved, so it's better. It was seen that it was better tolerated than the 100 milligram daily dose. So the aim of this study was to update the long-term follow-up of results of dasatinib at 50 milligram as frontline therapy. There were 83 patients who were randomized to the dasatinib 50 milligram arm, and this was a study where they compared 100 milligram dasatinib versus 50 versus imatinib 400. Right, and you look at the responses. The blue bar in the center is the response to dasatinib 50. Okay, and you can see every parameter, the complete cytogenetic responses, major molecular responses are far superior with 50 as compared to 100. The transcript levels of the BCR-ABL transcript levels, again, at 3 months, best with dasatinib 50, less than 1% at 3 months, best with dasatinib 50, and at 6 months as well. These are the cumulative response rates. Now, why is it that the dasatinib 50 works better than dasatinib 100? The answer is simple, and that is that it is much well tolerated. We know that in the first 3 months of treatment, it is very important to sort of not try and discontinue the TKI. And therefore, the compliance is better with 50, side effect profile is less, so no interruptions, and therefore patients actually tend to respond much better. Again, you can see an excellent EFS and OS and failure-free survival. So the results were that the rates of BCR-ABL transcript levels at less than 10% and less than 1% at 3 months, 96% and 77% respectively. 6% patient developed pleural effusion, much like with the 100. 4 of these required dose reduction. 2 patients failed to achieve any response. And at median follow-up of 24 months, none of the patients had disease transformation to accelerate or blast crisis. And the 2-year EFS and OS were 100%. So excellent results. And I have sort of moved on to dasatinib 50 for all my patients who are newly diagnosed CML CP, unless there's any contraindication. In this update, low-dose dasatinib continued to demonstrate faster and deeper molecular responses compared to standard dose imatinib and dasatinib. And the safety profile of low-dose dasatinib is consistent with no new safety signals as yet. Right. So the choice of first-line TKI would depend on the age of the patient, the comorbidities, concomitant medications, disease biology, adverse effect profile, and cost. Lastly, to discuss this trial, the Dasatinib RCT, where patients who were on imatinib and did not have a good response at 3 months, they were switched over to dasatinib, randomized to either switching over to dasatinib or randomized to same dose or a higher dose of imatinib, right? So imatinib 600 or 800 or continuing with 400 versus dasatinib. Right. Those who, so the major molecular response at 12 months for those patients, who were switched on to Dasatinib was 29% versus 13% for Imatinib, and this was significant. The 2-year cumulative MMR rate was 64% for Dasatinib versus 41% for Imatinib, and therefore the results of this study support the early monitoring of patients with treated with first-line Imatinib and suggest switching to Dasatinib in case of suboptimal response offers clinical benefit. So to summarize, Dasatinib is a small molecule inhibitor of multiple tyrosine kinases, including BCR-ABL1 and the SRC family of kinases. Dasatinib 100 mg once daily was associated with a deeper and faster cytogenetic and molecular responses than Imatinib in newly diagnosed chronic phase CML. Dasatinib 100 once daily provided the most favorable risk-benefit profile in Imatinib resistant or intolerant chronic phase CML, and with encouraging data for early switch to Dasatinib and frontline use of Dasatinib 50 mg once daily, and it overall has an acceptable tolerability profile. So with that, I end my talk, and thank you very much for listening.
Thank you very much, Samir. I think there are a few questions, and I request the organizers to project those questions. I will be very grateful if you can answer them, Samir.
Okay.
So the first one is, what is the best first-line therapy in pediatric patients with CML?
Difficult question. It's not been studied, so we can't be sure. I don't think we have clear data on that. So if you can extrapolate it, maybe it would be the same. Because as we know, the overall data in pediatric patients is sort of similar as compared to adult patients, and maybe extrapolation might be possible.
Awesome.
I think Dasatinib has a reply because we are participating in that trial phase 2. Dasatinib appears to be much better than Imatinib. Okay. No head-to-head trial. It's not possible pediatric patients, but yeah,
very few numbers.
In Journal of Clinical Oncology, you'll get to see that.
Okay.
Thank you.
The next question is, what if the patient presents with a huge spleen? Is the starting dose different with Dasatinib?
No, I don't think so. The size, the bulk of the disease, and would not sort of let us decide what the dose should be. Compliance, as we say, is important. So it's more important that the drug goes in every day rather than having interruptions.
Oh, compliance is a big issue. At least with Imatinib, it has been shown that
Yes.
At the end of 1 year, not everybody is taking it, even 80% of the. How do you ensure compliance in your practice?
Well, I think the best way to monitor it is looking at the responses. So the moment you see that the response isn't adequate, of course you could that sometimes they do look fair and lovely, and therefore they don't look fair and lovely anymore. You might think of they're not taking. Otherwise, the monitoring is the best way of identifying that, and then you can sort of cross check, ask sternly if the responses aren't appropriate. And many a times, as you correctly said, sir, they actually don't tell you, but they miss their medicines.
Right. The next question is, go back please. Dasatinib 50 milligrams is rational. Is it also ethical with current limited data?
It's a good question. Even Dr. MBA had mentioned it earlier. There's only one study, and therefore, can you be sure it's not in the guidelines? But we had a webinar with Dr. Elias Jabbar from MD Anderson, and he clearly mentioned that this is our standard of care at MD Anderson. We use Dasatinib 50 for every newly diagnosed CML now based on our study. But the results are really impressive, I must say. And since the last 4 months, I have also switched over to this protocol, and I really see excellent results. Somebody whom I have started with Dasatinib 50, and at 3 months he has a CMR.
Yes.
So
if you have started with Dasatinib 50, when will you consider increasing the dose?
So again at 3 months, if I don't see an appropriate response, then I would think of increasing the dose.
Right. But other than the molecular response, there is no other feature that you will use to decide.
Oh, sir.
Right. Next question is there any FDA black box warning for Dasatinib?
Not that I know of.
Right. So what are the toxicities that would, you would consider important when patient is being given Dasatinib?
Fluid retention, most important, sir. Pleural effusions. Sometimes some patients have come with a massive hydrocele, severe peripheral edema. These are common. And the incidence of vascular complications is again quite less, I would say. So I think fluid retention is something that we see most commonly.
Right. So there's a question in the chat box, not for Dasatinib but for Imatinib. How many of us do trough levels of Imatinib to confirm adherence or compliance? Would you recommend that?
I don't think so, sir. I'm not sure about that. I'm not. Maybe somebody else could answer this. I'm not sure. But we don't. I've never asked for it.
Dr. Tapan, any thoughts on that?
No, challenging, isn't it? Because if they are not compliant, they are not compliant. There may be, of course, so many issues, absorption, with other drugs, etc. I suppose it's a tough situation to do that and finally getting an answer. No, I don't think anybody is doing it in the country. Right. I have no idea.
Okay. So, sir, if I
Hari, please go ahead.
So we did two studies. In fact, Brajesh had done that study of trough levels as part of his thesis, and also my student had also done the study. It was extremely variable to get that. That was our experience, the trough levels. And the second study that we did to look at trough levels to see whether it correlated with early responses, actually there was absolutely no correlation to that. So we did it as part of a research work, but it never took off actually. Yes. Yeah.
But would you do it in normal practice?
No, we don't. No, we don't do it in normal practice. No.
Next slide, please. What is the risk of cardiac toxicity with CML TKIs, and how to monitor patients with cardiac comorbidity on Dasatinib? Samir, any thoughts?
With the Dasatinib, most of the times it is actually because of fluid overload that they, somebody who has already got a cardiac illness. Maybe I would sort of avoid Dasatinib. I might prefer Imatinib if it's, it might just tip the balance and, push him into CCF. There again, I might actually prefer a lower dose. If I want to start Dasatinib, I would use 50. And monitor would just be by symptoms, by doing an echo, chest X-ray, and looking at and monitoring these patients closely. What the risk of cardiac toxicity per se?
Pulmonary hypertension have been reported.
Yes, sir. Yes.
So, any cardiac parameters, troponin, for instance, or would you do a 2D echo to check?
Echo, yes. Echo, yes. I'm not sure about unless the patient has suggestive symptoms. Maybe ischemic events are that way quite rare as compared to Nilotinib. It is they're rarer. So echo would be more appropriate.
And how? So let's go to the next question. Is there data regarding continuing Dasatinib in pregnant women? And the second part is what if lady wants to plan pregnancy? I think it's not left. It should be lady.
Yeah. I don't think there's data on continuing Imatinib in pregnant women. It is recommended that you stop it in the moment a couple plans pregnancy. It is best to decide to stop the TKI and then let the lady become pregnant. And for that, you need to sort of ensure that the patient is in an excellent remission before stopping the TKI. Otherwise, it's best to sort of delay the pregnancy. And then once you stop it, you would monitor the, in her pregnancy, you would of course monitor the BCR ABL copy numbers closely.
There were some publications from India where ladies continue to have their pregnancy and take the medicine. And it was taken in third trimester or second trimester, and the outcome was normal child.
Yeah.
What are your comments on that?
Yeah. So basically, when we say that most of these drugs that we talk about, we know that it's a hydroxyurea pregnancy. The incidence of a teratogenicity is actually very low. It's not as though most of the patients are going to have it. It's a very small proportion of patients who have it, but you don't want that to happen. Therefore, you don't want to take a chance.
That is very.
That's all I can say.
Right. Any other questions over there? If not, then Samir, thank you so much for giving such a insightful lecture.
Right, sir.
We have a couple of minutes before we move on to the Professor Michael is just connecting, and I think that is great. Hari, may I request you to and the chairpersons to please introduce Michael, and then we can move on to his oration. Subhash, Tapan, and Hari, I think the three of you are.
Yes, Tapan sir.
Hari, please go ahead, please.
Yeah,
thank you.
Yeah. So we move on to our much-awaited talk, which is the oration by my friend and for colleague whom I have interacted with on several occasions, Professor Michael J. Mauro. He is currently the leader of the myeloproliferative neoplasm program at the Sloan Kettering Cancer Center. He's a very eminent person in the field and contributed significantly to the field of chronic myeloid leukemia. He had his medical degree from Dartmouth Medical School and residency and fellowship training at the New York Presbyterian the Weill Cornell Medical Center. And he's currently he's a professor at the Weill Cornell Medicine. And it's my great pleasure to invite Professor Michael Mauro to deliver his oration lecture today in the first Dalos meeting. Thank you, Professor, for accepting our invitation and being amongst us. And we look forward to your talk today.
Thank you. Can you hear me okay?
Yes, sir, we can hear you perfectly well, sir.
And I'm going to share my screen and let me know if that's coming through okay as well.
Yes, sir, we can see your slides.
Perfect. Okay. All right. Well, thank you so much. It's an honor and a pleasure for me to join you from New York for what I'm sure is a wonderful meeting in your hands. And it's an honor to be among friends and colleagues from far away who I've collaborated with over the years, who I've had the honor and pleasure of sometimes hosting at my centers in Oregon and New York, through the International CML Foundation and other venues. So it's always a pleasure to collaborate with you and to, again, it's a real honor. What a wonderful program, and what a wonderful honor for the honoree of this series. Again, thank you. So I'm not going to waste any more time and get into speaking about CML. Make sure I can advance my slides. There we go. So, first, I just want to offer a few words of best wishes and hope. We are obviously living through a very unusual time. I've had the pleasure of visiting locally in Chandigarh and other places in India, and be in person with you to share thoughts, to press hands, to take in how hard you work in CML. And of course, we can't. New York has been very hard. I've been here since the beginning of the pandemic to take care for our New York patients, and been humbled by what I've seen, and I know you're suffering as well. And I just wish that we all may persevere and get to the other side, as we say. Our country has done not a very good job, and I hope yours has done better or can do better than we. And as healthcare providers, I know we've all been working very hard. CML is a wonderful story, to speak about. I'm honored to be on the shoulders of real giants. The story of CML was one of discovery with genetics and basic cytogenetics, and then molecular discoveries, really unraveling the first human cancer linked to a sole genetic abnormality, and really the holy grail of cancer treatment. Could a targeted drug subvert a discrete molecular change and be meaningful? I don't think anyone really believed that. And my mentor, Brian Drucker, indeed actually a fairly tall man, so it's standing on the shoulders of giants. Brian, beginning in 1998, and I joined him shortly thereafter with Charles Sawyer, so I'm now have the pleasure of collaborating with in New York, really started the initiative for imatinib as a Ciba-Geigy compound, and then through Novartis, a gracious sponsor I know of this lecture series, to really revolutionize cancer treatment, to show us the path for targeted therapy. And we've come a long way with multiple targeted drugs, including a novel agent from the same side of industry, which I'll share a bit of thoughts on today as we talk about kind of new thoughts in CML. So we've really come a long way. And in 2020 and beyond, I think we really strive to make this a highly treatable and perhaps functionally curable diagnosis. I remember one of my good friends and physicians that I met from PGI in Chandigarh, who joined me in Portland for some time. And he mentioned to me that he told his patients who were diagnosed with CML, the first thing they should do was go to Temple and thank God that CML was a diagnosis they received because of the potential treatability and curability of it, rather than some other cancers. And I was always struck by that. And I often share the same thoughts with my own patients, that to reassure them that it is highly treatable and can, in many cases, with luck and the right resources and all, be curable. However, there are still unmet needs. And this slide, I just wanted to sort of summarize the thoughts we have related to TKI treatment and transplant. Now, the transplant is not accessible to all, even in the US, and often the age isn't right for CML, but we know we look for patients who have transformed, that they may not be a stable situation with TKI therapy, and transplant still may be the best path. We obviously pay attention to patients with highly resistant mutations like the T315I when we're able to identify that mutation. It is treatable with drugs like ponatinib, but it may not be treated successfully over the long term, and there may be long-term side effect concerns. Patients with imatinib failure who have a fairly innocuous form of CML without clonal evolution or resistant mutations, who have a good response to second-generation agents, if they're available, can do quite well. And we might be able to really defer transplant. But there are even patients with chronic phase CML who have difficulty with imatinib, may have complex resistance, clonal evolution by simple karyotype if it's accessible, kinase domain mutations, which can be helpful, or just clinically poor response, who may not do well over the long term, and in whom we have an unmet need. And of course, older patients are a special circumstance given the risks of transplant. So mainly T315I patients for whom previously we only had one agent, and patients with chronic phase CML with complex resistance, and certainly patients with transformed disease. And these are some of our key questions. So the spectrum of TKIs we have has grown, and imatinib has been with us, all of us around the world, for 20 years or so now. And second generation inhibitors have been available, I know to a variable degree, but have been present for many years, and we have fairly good data on their limitations in some cases, but also their benefits. Ponatinib has been available for some time now. We have drugs available in certain parts of the world, such as South Korea, Verdatinib, and we have novel agents in development. I want to spend a fair bit of time on what's new and what's coming down the pike with novel agents. So if we look at TKIs in development, I think asciminib, or ABL 001, really has moved along the furthest. And I'll talk about that in a fair bit of detail. We have a phase 1 trial that's been reported and published. We have a phase 3 trial, which is just about to report and is promising, and other trials. Again, we have Verdatinib, which has been studied in the second line and the front line, and has really shown how a single country can move a TKI through its regulatory pathways and add to the treatment armamentarium in their own country, and hopefully soon for the rest of the world. And then multiple drugs in development, including one coming out of Sun Pharma from India, from KO706. And the others on the list include PF114, HQP 1351. And I won't talk about flumatinib, but I'll mention as many of this as I can. So very much an active field still, despite how good we can treat CML currently. So asciminib really took things to a different step. We know all of our focus has been on specific inhibition of the ATP binding pocket of BCR-ABL, the dysregulated kinase in CML. We know that mutations in this kinase domain have been the focus of resistance. So development of a complementary allosteric inhibitor, in this case binding to the myristoyl pocket, could number one, give us the opportunity to combine therapies, much like we've been able to overcome infectious diseases such as HIV, and also give us an alternative treatment approach. So this was quite a good advance. Again, the concept here is that with formation of BCR-ABL or the BCR-ABL fusion, there's loss of the normal N-terminal myristoyl site. And by restoring that with binding of asciminib, you again gain favorable conformation for BCR-ABL and allow it to return to an inactive state and allow it to become regulated once again. So this mechanism is unique to this drug, and again complementary to the ATP binding pocket specific drugs. The phase 1 trial for asciminib, again, which has recently been published, December 2019. I guess that's not so recent, it's a year ago, but is a very large trial. It's actually still running. It's been running for 8-9 years now, which is very long and very big for a phase 1 trial. But I think it really shows the good problem we have with drug development in targeted space, where we have safe drugs with often not maximally tolerated doses or dose limiting toxicities, but desire to explore many different areas, different dosing schedules, different doses for different patient populations. In this case, higher dose for patients with select mutations. And then in this drug setting, combination therapy, which is still ongoing and had some work to be done here. The first report published in the New England Journal showed us the type of response we could see across chronic phase patients with or without the T315I mutation. This is a busy slide, but it just gives a sense for the hematologic remissions on the top line for patients in chronic and accelerated phase CML. Again, a much more robust chronic phase patient population. Accelerated phase was fairly limited. Cytogenetic responses as well, and molecular responses. But I think perhaps a better way to look at this would be here, because again, in a phase 1 trial where you're looking at dose and tolerability, you're going to have patients come in at various different points, and chronic phase CML patients can have a mixture of resistance and tolerance and have varying degrees of response loss. So if you follow this again busy table, starting from the largest arrows at 6 and 12 months, you see, for example, the greater than 10% arm here. This is patients who started with fairly high transcript levels, and it shows the proportion of patients who were able to shift into varying degrees of molecular response. Patients who started in somewhat better remission levels also shifting into different response categories, and even patients who had lesser degrees of resistance shifting into deeper molecular response, and so on. So, and with time, these numbers grew, the number of patients achieving deeper and deeper molecular response. So categorical improvement for patients with varying degrees of response with asciminib was really the rule. Adverse events were I think, very reassuring. I think we saw some, what I would call class effects, such as lipase increase and myelosuppression, and interestingly, some degree of hypertension. So the question of cardiovascular or vascular effects isn't ruled out. I think it's a very subtle finding, but does require some more attention, like it does in all drugs. And I think in a highly pretreated population, I think myelosuppression is not uncommon, and was, I think, commensurate with our experience in treating CML. So fairly reassuring AE profile. The group has presented on patients with the T315I mutation, and in particular those who have had ponatinib. This is our toughest population, often those who may not have many treatment options. So this was an expanded cohort of patients treated at higher doses of asciminib. And this is the sort of first blush of response at 24 or 48 weeks for hematologic response being retained or achieved, and cytogenetic remissions achieved. I think it looks very favorable for, again, a difficult population to treat, but the response at entry was variable, so we have to look at that in more detail. So the cumulative major molecular response rate, something we think of as a bit more important for long-term success for a resistant patient, is shown here. Again, encouraging. This is the phase 1 approach, but we see increasing accrual of patients into deeper molecular responses with asciminib with the T315I mutation. And probably the most important question would be, what about patients with prior ponatinib exposure? This is a comparison for patients ponatinib naive versus ponatinib resistant or intolerant. Not surprisingly, the patient group on the right is more difficult to treat, although there is activity, which is really encouraging. that you can bring patients into deeper molecular response even after ponatinib with this novel agent asciminib. I think we all agree that mechanisms of resistance after ponatinib may be complex, compound mutations and other potential mechanisms. So I think more time is needed, but this is very, again, reassuring. Safety wasn't any different in this cohort. Again, this is a smaller subgroup, but again, myelosuppression and some class effect with the lipase increase, no particular cardiovascular signal in this smaller cohort. There are more studies with asciminib ongoing, as you may be aware of, and just to mention that the ASSEMBLE, which is a randomized phase 3 trial of ABL 001 or asciminib versus bosutinib in a 2 TKI treated patient population, as described on the left, we're excited to report is met its primary endpoint and will be, we hope, presented as a late-breaking abstract at ASH, and quickly gotten into the literature for all of our review and perusal to show how we can move asciminib potentially into the treatment armamentarium, potentially initially as a third-line agent with more studies ongoing. The clinical trial program for this drug is broader. This is an additional trial called Ask for More, which is looking at optimizing patients who have had imatinib, but may need deeper molecular response. Again, this may be quite a nice approach to be able to add on to a safe and maybe easily accessible drug like imatinib with asciminib. Again, our first ability to combine TKIs. This combination has been studied in the phase 1 for safety and drug-drug interactions, which are interestingly unique depending on the TKI you combine asciminib with. And there, as you note, there is a switch arm to nilotinib, which will give us good comparative data to see about optimizing response for such patients. So look for this trial as it's now maturing and enrolling its last patients. What other drugs are on the horizon? I think I haven't heard much more about this agent, but coming out of Russia would be a drug PF-114, which was a structural analog of ponatinib, designed to perhaps shed some of the VEGF or other adverse effects of ponatinib. And we have good preclinical data in animal models to show it may behave similar to ponatinib. The clinical activity has been reported with cytogenetic and molecular responses observed over time in patients with 2 TKI failure or more, or with the T315I. So stay tuned for more on this drug. There may be a distinct adverse event profile with some dermatologic toxicity with psoriasis, like changes in the skin and other skin-related issues, including some higher grade. But potentially and hopefully maybe a more narrow side effect profile regarding cardiovascular or hypertensive adverse events. HQP1351 is a drug from coming up from China, which is again a ponatinib-like drug or ponatinib analog, a so-called third generation inhibitor, which again preclinically has been shown to be active against a broad array of mutations. May have some other kinase effects as well. So the adverse event profile and the initial safety data is quite important. This was a study in only patients from China with no ponatinib exposure treated, and we did see a very nice activity profile, particularly to patients with a T315I. So this would be viewed as an alternative to ponatinib, and again very active. The accelerated phase cohort, again smaller but also active. So I think the doses may have been established, and interestingly, this drug may be deliverable on an every other day basis. So I think studies are ongoing, both more in Asia and also now broadly globally, to see how this drug may fare with broader patient population and more time. And I think it'll be important to look at these agents in the ponatinib treated population as well as an alternative, just as the other drugs have. But so stay tuned for that. Coming out of India, and I'm encouraged to say from Sun Pharma's pipeline, would be KO-706, now known as vodobatinib. So this was the data presented at the John Goldman meeting in CML just a few weeks ago, where we have now a cohort of 30 or so patients treated at various doses. We've settled on the maximally tolerated dose, and I think this was quite appropriate to look at both ponatinib exposed and ponatinib naive patients who were slightly different with regards to their cardiovascular comorbidities, as I highlighted, and their mutational status. But I think the activity which we see in prior ponatinib treatment, cytogenetic and molecular responses, perhaps greater in the ponatinib naive population, is very encouraging. I think the adverse event profile was fairly limited with vodobatinib, and particularly we don't have discrete cardiovascular adverse events. More study is definitely needed, so I'm encouraged that we have multiple different agents which seem to be active in patients with highly resistant CML, potentially shedding some of the adverse events we have been concerned about with our current armamentarium, ranging from asciminib to PF114, HQP1351, and KO706 or vodobatinib. So I'm really encouraged to see that the space in CML continues to be filled with alternatives for us to develop and treat all of our patients. So in sort of the second half or the last part, I wanted to just sort of talk about the things that I normally talk about in the clinic with my patients is how do we manage CML in the States, and what's our approach and with guidelines. So, we try to be algorithmic when it comes to our diagnostics. We do try to continue to perform bone marrow studies, but probably more important is risk stratification, which is an interesting note because risk stratification can migrate as patients may present later. I think we see variability globally in the CML presentation with more higher risk or accelerated phase patients in different parts of the world. I think your burden of accelerated disease or higher risk patients is higher, and sometimes patients aren't able to be evaluated as rapidly. But that being said, this helps us with our approach and our management based in a degree in our older risk scores like the so-called and the Hasford score, and our newer scores such as the European scoring system, ETLS, and et cetera. So with basic data, we can really have a sense for our patients' expectations and potentially optimize their response. And of course, delineating between advanced phase and chronic phase really is a game changer in CML, so that the bone marrow and initial studies are quite important. Again, we try to be algorithmic, and I think it's a bit confusing if you look at our guidelines in the States, so that we just sort of list everything out. It really is in fairly most part based on risk. So we do, and we're an NCCN center, so our team contributes to these guidelines. And for a lower risk patient, we do still place imatinib as equal to second generation drugs. But for higher risk patients, based on the data, which I'll just show a few slides, and I think you are all familiar with, we know that the second generation agents, including bosutinib, now approved, although perhaps less used, can really bring more patients into deeper and faster remission, and therefore are listed as a primary treatment rather than imatinib. That being said, we have obviously looked to see how to optimize imatinib if used first with dose escalation or higher dose at initiation, and it still can be a successful strategy. The guidelines, interestingly, have not progressed, have sort of remained neutral when it comes to response milestones. We continue to emphasize early molecular response as our best predictor. Clearly, as a global community, we've looked at other questions, including the slope of improvement, meaning the having time of BCR-ABL transcripts, if we had the luxury to measure them very often. But if we have key landmarks, we can understand the trajectory patients are following if they have average risk chronic phase CML based on early transcript reduction. And we look towards major molecular response as a goal still, but you can see that really early molecular and cytogenetic response are some of the most important milestones, even in 2020 in the US for the NCCN guidelines, with less emphasis on the speed of major molecular response and even less emphasis on deep molecular remission, although that is clearly a treatment goal and drives treatment-free remission, which is a treatment expectation for many patients. When I talk to my patients, I try to emphasize to them that the PCR diagnosis is very important to judge their response trajectory, that cytogenetic response is very important, but really maybe in transit to deeper molecular response, and that we are aiming for deep molecular response. But again, this is really the best schematic and the direction we want to go in. But early molecular response, cytogenetic response, and major molecular response continue to be our landmarks. We know imatinib has served us very well in the long-term survival of patients, even those crossing over from cytarabine and interferon in the original IRIS trial is excellent. So imatinib has served our population in CML very well. I mentioned the difference between Dasatinib and Imatinib, and the final data from the Decision trial again showed that while cytogenetic remissions were superior and statistically significant, deeper molecular remissions and early molecular response were as well. And I think this is some of the main outputs of this study. Nilotinib looked very similar with cytogenetic responses being better, but early molecular response and more rapid and more comprehensive deep molecular remission, again as a way to bring more patients into potentially treatment-free remission category and open that door for them. That being said, you know, I continue to question what is the best treatment for chronic phase CML. If we look back, for example, to trials from the Australian group, the Title I and Title II, by using higher dose Imatinib and optimizing treatment with milestone responses and aggressive dose escalation or switch, we can see that major molecular responses at early time points, which are some of the most important, can really match or even exceed those of the second generation inhibitors. So I really applaud the persistence of the strategy of optimizing Imatinib with dose escalation and early switch, rather than always entirely adapting a second generation inhibitor approach in the treatment of chronic phase CML. We focus a fair bit based on our population with heavy comorbidities in the cardiovascular and cardiopulmonary space on the fact that the patient's comorbidity index is very important. And while response isn't different for patients with different comorbidities, we see that their comorbidity index can really have a strong impact on their survival. So in turn, what we're saying with this data and this is from Suzanne Saucelay from the German CML study group, is that a patient's other health issues can become actually more important, assuming they're doing well with their CML. And of course, if their TKI therapy is interfering with their comorbidities or augmenting their comorbidities, it can be a real problem. So we need to take care of the whole patient and think about the comorbidity issues, especially in the sensitive CML patient responding. The drugs obviously have a variety of different side effects, and we continue to query these emerging and late toxicities as shown on the bottom. And I think, for those of us who have the luxury of using any of these agents, it can be, especially for those treating fewer patients, it can be somewhat daunting. But thank goodness we have so many options, and we have the ability to optimize therapy, to work around selective adverse events. And I think we're learning much more about select adverse events. Adverse events, again, may be linked to comorbidities. And this is just a large data set from Europe showing how often a CML patient may have, for example, cardiovascular or other significant comorbidities. And it comes around about 40–50% of cardiovascular or other significant comorbidities that could drive adverse events with TKI. So this is again, a strong part of the agenda. Why? Because we know that vascular occlusive events have been shown with all of the TKIs, really. I don't know if any TKI is entirely scot-free. Potentially Imatinib is the comparator. And data very early on I was part of did show that Imatinib may be very neutral and in some ways offset some of the cardiovascular metabolic changes. But each TKI that's been developed and each new TKI will need to be looked at carefully for off-target or vascular effects given this type of meta-analysis data. Nilotinib, unfortunately, was as a broadly used agent in Europe and in the US and really globally, unfortunately showed us the clear picture that there is a difference between the adverse events compared to Imatinib, and there may even be a dose-dependent effect, which is a fairly strong argument of an intrinsic drug toxicity. So it behooves us to continue to monitor. And of course, Ponatinib, this is from the PACE trial and the phase 1 trial combined, where upwards, as you can see, of between 25 to 50% of most of patients would have some cardiovascular related adverse event. Now we've looked at this data in multiple different settings, and adjudication has been performed and will be disseminated. So sometimes it's hard to understand how strongly we view it as a true cardiovascular adverse event or a drug-related adverse event, but it clearly warrants attention. We've developed some guidelines which have been published. This is a table from an ASH publication on the right, which, when available, cardiovascular testing can really help watch the safety of these TKIs, especially those with risk. Which tests are required in which setting, I think, are still under investigation. but just a simple clinician's assessment of blood pressure and symptoms and blood sugar and basic laboratory assessments can make a big difference, because some of these problems can be picked up early. There are studies ongoing in the States looking at what tests might be helpful. This is one that we helped sponsor through Bristol Myers Squibb, where newly diagnosed CML patients, irrespective of their TKI, are having coronary and vascular testing done routinely to see what tests will give us best information. Other sort of hot topics I might say would be reducing TKI therapy once patients are in response. I think I have increasingly been quoting Delphine Ray's data for the reduction in Dasatinib for patients who had achieved good molecular response to show that, number one, continued molecular response was achievable. And for those who essentially had a bit of prelude, treatment-free remission or treatment cessation was not less successful, but in fact seemed more successful in this group of patients. So the second quote that's often heard in the States when we're talking about initial therapy or second generation TKIs is lower dose Dasatinib. Many have stated this is compelling data, but hasn't changed the standard. But it appears that through the single center study at MD Anderson, the 50 milligram Dasatinib performs very well. Here's the data. If you look at Dasatinib 100 versus Dasatinib 50, with molecular and further responses. Ironically, the lower dose Dasatinib compares favorably to Imatinib and also favorably to higher dose Dasatinib. So take this under advisement. I wouldn't say the standard has changed, and these are historical comparisons, and there are some details that require attention. But I think the word is that less may be more in this setting. And then how do we view treatment-free remission in the US? I think we have our guidelines, which I think are perhaps the most liberal, where patients with chronic phase CML who have no signs of previous progression, who have had at least 3 years of treatment and 2 years of very deep molecular response, who have the ability to have sequential testing, have the ability to be followed very carefully, which isn't always possible. Even in my office and even in my practice, I sometimes lose patients lost to follow-up, which is very frustrating around this question. So we can follow the trajectory and see if remission can remain stable off treatment, and of course retreatment can be initiated when it's due. So in order to stay on time, I just thought I'd share some closing thoughts that we really have excellent therapy and a palette of choices, hopefully for everyone. Imatinib really has proved its worth and remains. It has not been displaced from the podium, if you will, and remains an excellent treatment for CML, and it's branded, its generic forms, as I know many of you use. Second generation TKIs can really help correct suboptimal response, can allow us to navigate around side effects, can rescue treatment failures. It can be used in the frontline setting for faster and deeper responses. Overall responses are not drastically different than Imatinib. And again, there are different strategies one can take, including rapid dose escalation and optimization, rather than broad adaptation. In the US, we do recommend it for higher risk patients, but thank goodness we have such good arguments and good problems around optimizing frontline therapy. Each second generation drug has distinct toxicities, particularly the vascular story remains still unsettled, still under investigation. Treatment-free remission, again, where it's possible and feasible, is an exciting advance. Truth be told, it's only successful half the time, though, so we need to do more work there. And hopefully in the beginning, I share with you some of the most exciting research into newer agents, including Asciminib or ABL 001, which is moving forward very fast. And I hope we all can continue to treat our CML patients better and better as the years pass and be able to see each other in person and share thoughts together. So thank you for your attention, and I'll open it up for questions.
Thank you very much, and maybe request the chairpersons to moderate the question answers. I think the chairpersons themselves got several questions, so please go ahead. Tapan, Hari, Abhay, Bhave, Dr. Advani also had a question. Sir.
Right. Thank you, Dr. Mauro. Very educational and practical talk.
Thank you.
Got it. So some questions.
Yes.
So the first one is about any hope for first-line combination therapy of TKIs in near future?
So yes, I think we're seeing development. You may be asking about for Asciminib. could we have a frontline combination? And that is being looked at as monotherapy. So asciminib is already being proposed in the frontline setting. And as you see, it's already being used as an early optimization. So I believe that is the future, that if we can, show that we can subvert resistance and really increase the rate of early response, that would change the natural history even further. I mean, I think ponatinib, when it was tested in the frontline setting, really showed that higher rates of response are still achievable with more potent agents. So either as a monotherapy, newer agents, or combination therapy with the ability with asciminib as an allosteric inhibitor, I think that may be quite intriguing in our goal.
Thank you. Could I have the next question? Right. This is about pregnancy.
One of my favorite.
Molecularly undetectable leukemia, and she becomes pregnant.
Yeah,
what do you know?
I think pregnancy and CML are very common co-agendas for patients. I respect that, especially for our younger women, who family planning is very important. Ideally, if a patient can meet the expectations of treatment-free remission, meaning if they are eligible for treatment cessation, I would say in principle, they may be eligible for pregnancy. In the ideal world, it would be nice to have a dry run, if you will, and have them go into a treatment-free remission. So the question was about someone in complete molecular remission on treatment who becomes pregnant. If they're pregnant, they need to stop therapy. That we don't sanction TKI use, especially early. Although late, I think there's increasing discussion about the ability to use it for perhaps to rescue a patient who's relapsing, perhaps to treat a patient pregnant who's just been diagnosed, which can happen, or a patient who unfortunately has more significant relapse. So in essence, if they can get to deep remission and appear eligible for treatment cessation, I think that's the way to go. If they can have some time off treatment to show they're not going to rapidly relapse, that's even better. And all the other circumstances, I think we're getting more and more comfortable with. We've just published a position paper, a group of global collaborators on this, so we need more information for everyone to work with around this important question.
Thank you. The next question, a little difficult to understand, is the best sequence of oral TKI in a young person and with no comorbidities. So we don't know about the responders or patient intolerant or developing resistance. We have no idea about these questions. Would you be able to answer this one?
I'll catch any ball you throw at me. I'll say with this type of question, I see a 32-year-old with high risk disease. Right, so that immediately wants me to think that a second generation TKI may be advantageous, whether it was as an initial therapy or as a salvage therapy. There may be, fortunately, lesser difficulty with comorbidities or predilection to comorbidities or complications. And I would favor, second generation TKIs. When it comes to safety and rank order, I think, they're all highly effective. Nilotinib has probably about the best frontline second generation TKI data, although Dasatinib and Bosutinib are very similar. When it comes to salvage, I think Dasatinib perhaps has a bit of an edge as it covers a bit more broader mutational spectrum, may have a little bit different adverse event profile. Bosutinib is a very good drug to work around toxicity such as Dasatinib pleural effusions and other issues or vascular risk. So and is obviously also licensed in our country as a third line. That's why asciminib was compared to Bosutinib in the third line. So I think we have a lot of things to talk about in a patient like that.
Thank you. The next one is about Tfr. Someone with a high dose imatinib, then stop treatment, there was a molecular relapse. What would be the best treatment option?
Another great question. What a great audience this is. So this sounds like we pushed the imatinib to the limit, higher dose to get someone to TFR, but now they've been unsuccessful. How to get someone perhaps off treatment a second time is an active area investigation. I work with a group of collaborators in the US called the CML Consortium, and that's actually our focus. So we've launched some trials into combination approaches. We have a trial combining with TKIs with ruxolitinib. There'll be a combination trial with any of the available TKIs with asciminib, the drug we talked a bit in this discussion. I'm excited to say. So a combination approach, and that's experimental. I wouldn't recommend that outside of a trial. But I think that question, or that person was asking, should I switch to another drug as a way to get them to second treatment-free remission? I would look at the time. I think time on treatment and time in deep remission are the best predictors of treatment-free remission. So if there was less time in deep remission, even though high-dose imatinib might have been used, just simply going back on high-dose imatinib, if it's tolerated, may be a safe and reasonable first step. And then with time, we'll maybe learn about the need to switch or the need for a combination as a way to make it happen successfully a second time.
Thank you. Next is about insurance cover. You can read it and answer. I can't understand it very well.
Well, this person obviously knows how things run across the many ponds. So yeah, you must be all watching our politics and our country with either aghast or I don't know what. But so in the States, some people have different coverage for their care, whether it's the beginning of the calendar year or the end. And some of them, it may be the reverse, is that they often have very high copays in the beginning of the year when their insurance has just opened up for that year, for example. So how do we manage? Some patients have real difficulty with copays. I would say that the biggest help, I'll give the nod to industry. Many of the companies, the sponsors, have patient support and patient advocacy programs where they're able to help patients with very high copays or very high, what we call out-of-pocket expenses because of this donut effect. As you know, donuts have holes. So our US healthcare insurance has holes and people can really get stuck in them. So again, I would just say that we often manage by creative support from either pharma or sometimes charitable organizations.
Thank you. Could you have the next question? Right, quantitative BCR-ABL at baseline. Your take on it. ELN says not required.
I think that's, I can see the person who asked the question quite a good one. And I think it's controversial because we do still aim to individualize the trajectory of CML response. And again, there's a fairly robust field emerging regarding both the halving time and actually now the doubling time of patients coming out of treatment-free remission. So I think the kinetics really mandate you having a baseline number. It's not mainstream, and I think often we can generalize and look at early molecular response as a categorical effect below 10%, but some people do start at different points. So I acknowledge the wisdom of the ELN and the physicians that represent that, I think, but remember the guidelines are just all of us getting together in a room and saying, where's the data? And because we don't necessarily put all of our weight on one's individual rate of decline or their individual number, I think it's, if available, it's helpful and may someday be more helpful.
Thank you. As you say, recommendation is recommendation, not a binding. Thank you. Next is from my co-chair, is asciminib in TKI failure.
Yes, I think CML is a remarkable disease where in the setting of salvage with what might look like very complicated and resistant disease, we've seen some patients revert to a very stable course and appear to be like patients with ease of remission the first time around. I can tell you from personal experience that there are patients on the asciminib trials in whom we really have been pressing our sponsor to say, can we think about treatment cessation? So if you believe that patients with 3, 4, 5 TKI failure with disease resistance look as good as patients we would consider treatment-free remission, I think transplant may be subverted by such corrective approaches. So I'm really encouraged by that. Ponatinib has a similar story, and it actually becomes a more obvious agenda because of concern about long-term risks of continuing ponatinib. So I think it's possible.
Thank you. Next one is from Dr. Bapna. How deep should we go and strive for it? The response.
Yes. I'll make a general statement that I would say I think the absolute numerical depth of CML remission, number one, is dependent on your assay. Number two seems to have become less important over time. Number three is we're intrigued by the fact that the best of our patients who've, the original French patients who went on treatment cessation under François Mahon in the original study, when looked at with detailed allele-specific or DNA-based PCR, have BCR-ABL signal. 10, 15 years after treatment cessation, they still have the footprint of their disease. So if data holds true, for example, like the Euroski trial, treatment cessation in a patient with a stable deep remission for a crucial amount of time, even with detectable transcripts, even above MR 4.5, may biologically not have, they may not relapse, and we may have essentially discovered a new category of treatment-free remission, still with molecular footprint without biologic capability of relapse. This story mirrors, I think, rarely some other diseases such as core binding factor AML, where you may see a signal, but you don't actually see a biologic relapse. I don't think that's exactly the same analogy, but it has been seen before, and CML presents a unique case.
Thank you. And this is a question for Dr. Advani himself. What would be the baseline, first line treatment? First generation followed by second generation, or we should go for second generation right from the beginning?
You know, I tried to highlight in my words that I do believe there is a path forward for many patients with a first generation drug in the frontline setting. I'm a big personal fan of higher dose imatinib akin to the title trials. I'm a big fan of minimizing risk. I'm a big fan of risk stratification. So if you hear those words, you're probably guessing that I try to work around and find the patients in whom I think imatinib may be a reasonable first treatment, lower risk patients where comorbidities may be high, higher dose imatinib for patients who have maybe average risk. I still use second generation inhibitors in the frontline, but I don't know if we have to apply it universally. So I'm not really answering the question, I'm sort of hedging, but I would say that I think there's clearly a place for imatinib in the frontline setting for many patients.
Thank you. Dr. Menon is asking if someone responds to ponatinib with T315I mutations, do you consider transplant for everyone?
So that, I think you pull in all the factors when you have a case like that. If it probably depends on the transplant risk, the patient's willingness, the concern about long-term ponatinib exposure, and the depth of response. So, you know, best case scenario would be a patient who, well, the best case for continued ponatinib or avoiding transplant would be a patient in whom the transplant risk is higher, the transplant option maybe not as optimal, who has a very good response to ponatinib, perhaps who has been able to be dose reduced to lower dose ponatinib and remain stable, and in whom we can monitor their cardiovascular risk status carefully to understand that subsequent ponatinib may be safe. And as I mentioned earlier in the other question, you know, can we consider treatment cessation in such a patient population? I think that's an intriguing question. There's limited data. The late Gene Curry from the US in Augusta, I know him and his colleagues published a small paper on treatment cessation in highly resistant patients, even transformed patients, but more research is clearly needed in that space.
Thank you. Dr. Bhabe is asking about bosutinib as a first-line therapy because India has a generic bosutinib. Should we use it?
I think bosutinib is a very good drug. It has some unique side effects. So I'm not sure how you handled your generic variety, but the commercial variety I use in the United States, I tend to want to start at a lower dose and be very careful about early side effects, knowing that GI effects, diarrhea, and liver enzyme elevations can really sneak up on you if you're not careful. So I tend to titrate. But you know, if the data is quite clear that bosutinib offers similar advantage to imatinib when you deliver it. So if your generic is similar in behavior and you can use it and with a bit of titration, I think that might be a very reasonable option. And if it's lower cost and accessible to patients, it's a great tool.
Thank you. In your clinic, how do you manage the withdrawal symptoms after TKI stoppage?
Nothing proactive, just a lot of communication and discussion. First off, we warn patients because I think, fortunately, maybe in the States, maybe everywhere, people are expecting that the sun will shine brighter and the air will seem sweeter the days they're off TKIs, and that's not always the case. So we warn people. We try to see them in the 4 to 6 week window when I think it often is peaking. We'll recommend simple interventions. I use simple non-steroidal anti-inflammatories and actually histamine blockade because I think KIT reactivation may be potentially a mechanism by which TKI withdrawal can occur. And I just try to reassure that it often will abate with time. It's rare to have a patient in whom it persists. But you know, TKI treatment, both the on and the off, really can unmask or interplay with other comorbid health conditions, especially immune inflammatory conditions in some patients. So we really have to think about this.
Thank you. I think we have finished with our questions. Thank you so much, Dr. Mauro, for spending so much of time with us early in the morning at New York. Thank you so much.
I think it's a bit later for you locally, but again, I thank you for your invitation and your great questions.
Yeah.
And please have me anytime. I cherish the communications and collaborations with all of you. And be well.
Thank you so much. Long ago, 30 years ago, I spent some time in MSKCC with Subi Gulati, Barney Clarkson, and Abel Strife. So
I knew best. I knew best Dr. Gulati, and I worked with him when I was in my training. But it's small world, small world.
Yeah.
Thank you so much.
Thank you, everyone.
Thank you. Thank you, Michael. Thank you. Thank you so much. Thank you. Thank you for your wonderful talk and interactions. Thank you.
Thank you very much, everybody. It was an exciting meeting, and there were so many interesting questions that just kept coming. So we are a little off time. We will now sign off for today and request Dr. Advani to give the final comments. Can we ask you to unmute, sir? Sir, you are muted. Can you unmute yourself? Sir, that was unmuted.
Yeah,
Correct.
I think we had a great time. We have learned so much in such a short period about CML, and we are really looking forward for the newer and newer approaches and maybe little better understanding. Thank you.
Thank you, and please join us tomorrow for the second day of this conference. Good night, stay safe and stay healthy.
Thank you.
Kashish, you can end the meeting now.